Thank you very much for coming to join us with this meeting. Also to all of our guests, our staff and media personnel and those coming to present to us this morning. We have a continuation of our NHI public hearings this morning, and we will be receiving presentations from the Competition Commissioner, the Commission for Gender Equality, and from Solidarity this morning. Ms. Majalamba, if you can please let me know what our attendance register looks like and whether we have any apologies. Thank you.
Good morning and thank you, Chair. Present is Dr. Jacobs, Ms. Geller, Mr. Sokacha, Dr. Harvard, Mr. Siwela, Ms. Clark, Ms. Wilson, Ms. Ishmael, Ms. Chirwa, Mamuhlengwa, and Mr. Van Staden. I've received apologies from Dr. Tembe Gwayo, Ms. Sugers, and Mr. Imamshi. Thank you, Chair.
Thank you very much, Ms. Majalamba. Honorable Van Staden, I see that your hand is raised. Can I take it now?
Chairperson, good morning. Excuse me, good morning, Chair and other colleagues. Now, I just want to have clarity on the written submissions which was done by Parliament and through our public participation process. I don't know if you want to handle it now, if you want to me to bring up a matter at the end of after the submissions were made today.
Thank you, Honorable Van Staden. I think if you can hold on to it until we are done with the submissions, it would be great.
Thank you, Chair.
No other hands, honorable members. So we've had our attendance register, and I've told you what our agenda is for today. I will have to remind you, though, that all who have logged into this virtual meeting of this committee would have to abide by the rules of the committee and of Parliament. I would like to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. We shall now proceed to the business of the day, and we therefore welcome the team from the Compensation Commissioner, or the Competition Commissioner rather, Ms. Majalamba, who is leading this team, or if the person who is leading the team would please switch on a camera. I see Ms. Bowler on the system. Switch on the microphone and their camera and just introduce the team, and they could go straight to the presentation. Thank you.
Thank you, Chairperson. My name is James Hodge. I'm the Chief Economist of the Competition Commission, and I'll be running through the presentation today. I am joined from the Competition Commission by our Chief Legal Officer, Bake Majenge, also the Manager in the Office of the Commissioner, Andile Gwabeni, and 2 principals from the Advocacy and Economic Research Bureau, Silelo Ramahlola and Hariprasad Govinda. I will proceed to share our presentation. May I proceed? I assume that everyone can see our presentation.
Thank you, Mr. Hodge, and again, welcome again. You're very welcome to continue. I can see your presentation and also hear you. Thank you.
Thank you very much, Dr. Jacobs. And to start off, to thank the Portfolio Committee for giving the Competition Commission an opportunity to come and present on our written submissions around the National Health Insurance Bill. We certainly appreciate that. Let me just jump straight in. I think from an overall perspective, the Commission supports and acknowledges the overall objectives of the bill. And I think we often oversee a health sector which is full of market failures and understand that a unified healthcare system for the country would be beneficial. Our submission is primarily directed at the application of the Competition Act, and in particular, Section 3.5 and 58 of the National Health Insurance Bill, which would limit the application or eliminate the application of the Competition Act to various activities, and we'll get to that. I think in summary, it's not clear to us from the bill why an exemption is needed in the first place, but even if there are elements that need to be exempted, that these exemptions are unnecessarily broad as they are worded, ambiguous, and in fact, this poses a lot more risk to the NHI and whatever out-of-pocket expenditure that may occur outside of the NHI system to quite likely anti-competitive conduct by private healthcare providers. And that's going to ultimately undermine the purpose of the NHI and its ability to achieve its objectives. We also think this broad exemption that sits within the bill is unnecessary, as there already exist mechanisms within the Competition Act to exempt either genuine non-commercial activity, but also we have additional provisions such as ministerial block exemptions, which have been used recently during the national state of disaster to great effect and can be a lot more targeted and flexible way of dealing with any need for an exemption. I think to highlight that currently GEMS, which obviously acts as a single purchaser for government employees in terms of their medical needs, that is not exempt from the Competition Act, and we haven't had any issues or problems from them. So as I said, there's 2 sections that we're focused on. Section 3.5, which refers to the application of the NHI Act, and there it expressly states that the Competition Act of 1998 is not applicable to transactions concluded in terms of the Act. So that would be any transactions in terms of the NHI Act. Section 58 and the schedules that follow look to amend Section 3 of the Competition Act, and for the members' purpose, Section 3 in the Competition Act is about the application of the Act, and it begins by saying this Act applies to all economic activity within or having an effect within the Republic, with the exception of, and the bill seeks to insert within that list the exception of the operations of the National Health Insurance Fund established under Section 9 of the National Health Insurance Act 2019 as a single purchaser and single payer of health services. But it extends to the operations, which is a broad term. So just in terms of the main elements to our submission, we would say Section 3.5 would effectively exempt all parties to a transaction, because if the transactions concluded in terms of the National Health Insurance Bill would be exempt, then all parties to the transactions are. And it wouldn't just be the NHIF itself. It would include all your private healthcare providers, pharmaceutical companies, medical equipment, PPE, etc. So anyone that supplies and contracts with and engages in a transaction with the NHIF or its constituent bodies. Section 58 is a bit more ambiguous because it refers to the operations and has a broad reference. but arguably the operations is very broad. But again, it's likely to extend to third parties because Section 3.5 already achieves that purpose, that all parties to a transaction. But it could be even more far-reaching if we look at the total operations that the NHIF undertake, including some of the parties that are contracted to assist the NHIF in its operations. So what would the effect of these provisions effectively be? That it would render the Commission completely unable to investigate and prosecute any anti-competitive conduct. And this would include collusion, abuse of dominance, so excessive pricing, and potentially even merger control, depending on how the courts interpret that. But of course, if there is no ability to investigate and prosecute collusion or abuse of dominance, then there is little deterring private sector companies in the healthcare industry from engaging in those practices because they are effectively immune from prosecution. And that would be to the detriment of the NHI itself, because the purpose of the NHI in bringing in a single purchaser is precisely to try and negotiate better prices for healthcare services. And it's those lower prices through a national health insurance that are designed to achieve that sustainable universal access to quality healthcare services. So giving the private sector a free ride on the Competition Act would be against the NHI's ultimate objective. What we have done, and this is in the written submission, is look across other regions where there is a social health insurance, a national health, social health insurance, and to see whether in fact these sort of provisions exist or not. But if we look at Europe, for instance, where most of the countries do have a form of national health care, there are very narrow and narrowly construed exemptions. And this is really to entities that are not commercial undertakings at all, but also those that are entrusted with the operation of what's called a service of general economic interest. But there is no blanket exemption for the social healthcare system. And in fact, what we see, and this is referenced in the written submissions, there is quite extensive competition prosecutions around collusions, abuse of dominance, and even exercising merger control throughout Europe. And it's precisely because a national health system has to contract with private providers that may still engage in this abuse, is why there isn't this broad exemption in those countries. I think the additional concern from the Competition Commission's perspective is obviously the final design of the NHI is not complete, and the NHI bill refers to some future legislation and regulation that may be formulated. And so in that context, it's also premature to pass a bill that would exempt all activity when it's unknown what that would be. It would be preferable to understand some of that activity before just granting such a block exemption. So just to highlight some of the risks that the exemption would expose the NHI to, and of course the citizens of the country. Collusive tendering. So collusion is designed to try and raise the price, and it would frustrate the ability of the NHI to get the lowest price. I think collusion is quite commonplace in the country. The Commission has exposed a lot of collusion for state contracts and continues to do so. So it's not as though the state is immune to this. We've exposed collusion in healthcare and healthcare provider services to the state. So there's no reason why the NHIF would not face this risk. And as I mentioned earlier, the fact that the transactions would be exempt would mean that in effect there's no deterrent effect, which would make collusion far more likely than it is currently, where there is a deterrent effect. I mentioned earlier as well that Europe, which has a national health insurance, has prosecuted numerous cartels in the healthcare sector. And that shows that, again, once you have a national health insurance, it doesn't prevent that sort of conduct occurring. The abuse of dominance would also be an element. We would highlight probably excessive prices as the most likely here. And effectively, pricing at excessive prices undermines the ability to fund universal healthcare, because it means that the funding that the NHIF does have doesn't go as far. And of course, there would be little to deter this conduct if those parties couldn't be prosecuted. I think it is important to note that a lot of the concerns, and this was the subject of a health market inquiry by the Commission, around the high cost of healthcare is often rooted in the concentration and supplier buyer power at different parts of the chain, be it hospitals, be it pathology, be it pharmaceutical companies. And a single buyer doesn't necessarily alter the situation. I mean, we already see that the state as a supplier of public service and a large purchaser still cannot bring down the cost of some of life-saving drugs to make them affordable and to roll them out within the public healthcare system. I think we've seen, and this is maybe an interesting point, our recent actions around the COVID PCR testing and antigen testing that we engaged on late last year was done in the context where there had been an exemption granted for the Department of Health to in fact engage the pathology groups around lowering the price of these tests. So the existing, that sort of infrastructure of an oversight and a negotiation still didn't yield low prices. And we were forced to intervene, and not having done so would have left those prices still very high. We have a number of open investigations also on life-saving drugs where the lack of alternatives and the must-have nature of it means even if you have a single purchaser, that the supplier of the drug also has a lot of bargaining power in this process. Arguably, it would also expose the NHI to growing concentration in the healthcare if the court saw this broad operation and transactions exemption as limiting the Commission's oversight of health-related mergers that would engage with the NHIF. Already, we have seen a period where hospitals have, the three big hospital groups have gradually cemented a strong position in the economy, and our health market inquiry has warned against allowing future mergers in hospitals, and we recently succeeded in stopping one of them before the Constitutional Court, as it was deemed to be not in the interests of the Constitution and access to healthcare. So quite clearly, the court in that instance identified that growing market power and potential higher prices would result. We also have many examples in Europe in countries where, again, they have a national health system, but much as envisaged here, they will be contracting with private players. It's also maybe a last point to note is that nothing in the bill or legislation seeks to replace the role of the Competition Commission. So there is no aspect that looks at oversight of competitive conduct and penalties. And one of the particular, I think, deterrent effects of the Competition Act is the high penalties that can be imposed of up to 10% of turnover or 25% for a second offence. And that does have a stronger effect, the risk of being caught and prosecuted. I think even if the courts were to hold a far more narrow interpretation around the NHIF itself and not the private healthcare industry, there's still some risks, we would say, of a sort of blanket exemption, because already within the bill, and as we look across it, there are areas where there may be potential competition aspects, and maybe that competition shouldn't be unduly restricted, and where that competition could be abused through collusion or abuse of dominance, as I've indicated. And certainly as the design is teased out, to start with a bill that exempts it, and then to find that one wants competition and oversight in particular areas, makes it very difficult to retrospectively then alter the bill, as legislation takes time to change. So I've put some examples on the slide of where there might be contracting and competition. It's unclear at this stage, but we give a full list in our written submissions. But maybe let me end off by looking at the alternatives which already exist within the Competition Act. And we can take questions on these as well. But certainly we're very willing, and have indicated in our written submission, to work with the National Department of Health and even the NHIF, once it's constituted, through a memorandum of understanding, to explore where an exemption is actually needed and the rationale for that, and then to provide a suitable exemption where it is required. And certainly our track record, as I indicated, has been to grant exemptions where they are required across many industries. We have granted exemptions to the National Health Hospital Network in terms of allowing those hospitals to collectively negotiate tariffs, but also collectively negotiate the purchase of consumables and pharmaceuticals. We gave a healthcare exemption at the beginning of the national state of disaster in order to allow coordinated response to the pandemic. And that has been very effective. And that was done under the minister's block exemption. There's also many other instances in many other industries where we have simply granted exemptions, and we're more than happy to engage the relevant parties. Maybe as a general framing, just in terms of Section 3 of the Act, it applies to all economic activity. And there is a provision in there already, which is Section 3(1)(e), which has the exception of concerted conduct designed to achieve a non-commercial socio-economic objective or similar purpose. Now, certainly our view is that a lot of what the NHIF undertakes is commercial activity or economic activity, but there are elements to that which may not constitute it. And we can draw on precedent from the EU in order to examine what aspects may already fall outside of the Competition Act and would not require an exemption per se. The second alternative is to have specific exemptions under Section 10 or block exemption, which is Section 10(10) by the minister. So we can grant exemptions where there's an application, and there are certain categories set out in Section 10, which arguably the NHI bill might fall within, such as designated industries by the minister. The Section 10(10) is the minister can provide block exemptions. By block exemptions, that means whole categories of agreements or practices, rather than just the sort of piecemeal applications. And I mentioned earlier, this was used to good effect in the national state of disaster. I think what is important relative to legislation is also that Section 10 is done through regulation, which can be issued very rapidly. I think the healthcare exemptions was granted within a day after the request came through from the Minister of Health, but it can also be changed rapidly and reversed if need be, if there is abuse. So I'd mentioned earlier what we saw as maybe the abuse by the pathology labs in terms of that exemption, and have called for the exemption that was granted to be narrowed now with the exclusion that private parties can't come together to discuss, even with the Department of Health, pricing in the attempt to lower prices. So unlike legislation that takes time to change, regulation can be done relatively rapidly. So just to sum up our submissions, we're of the view that a blanket exemption is not appropriate. We don't fully understand what the rationale for that, and it's not set out in the bill, but it exposes the NHI to actual risks and in fact undermines what the NHI is trying to achieve. So in the interest of pursuing that objectives, we think it should be dropped. But it's also unnecessary because there are mechanisms within the Competition Act that can provide that exemption where it is genuinely required and where we can engage with the NHIF or the National Department of Health as to why it's required and how it may be narrowly framed. If one reads our block exemptions for the pandemic in healthcare, they are quite specific as to which healthcare providers, what activities by them, whether it's, for instance, just looking at treatment protocols, but also specific in what is actively excluded, such as discussions on price. So, and controls can be put in, such as the requirement for minutes and informing the commission or getting the permission from the minister to initiate and activate some of those exemptions. So regulations and exemptions can be far more closely worded. I think finally, we would just also recommend that there is some engagement around the issues raised by our own healthcare market inquiry. It is the case that there is a transition period, and it's also the case that the NHIF will contract with private parties. And so the structure of the healthcare market and how it evolves in this interim period, I think, is important to how successful the NHI is in bringing down prices and ensuring more universal access. And certainly we will continue to be active in merger control and enforcement in the healthcare area in the interim. So, Chair, thank you very much. That is the end of our presentation. As I indicated, we have a broader team to assist with answering questions that the Portfolio Committee may have.
Thank you very much, Mr. Hodge. We appreciate you coming to make this presentation to us, you and your team. There are a number of members who wanted to raise questions with you, and I'm going to name them in the order that they will be raising those questions. It's Wilson, Hlengwa, Sukacha, Yela, Clark, Harvard. If I have missed any honorable members, please indicate now.
Chirwa, Chairperson.
So Chirwa is next, and then I see on the platform also Munyai. Anyone else? Any other members would want to raise any questions?
I'm covered. Thank you, Chairperson.
Thank you. So I'm going to repeat the order. Wilson, Hlengwa, Sukacha, Yela, Clark, Harvard, Chirwa, Munyai, and Suwela. Thank you very much. You may start, honorable members.
Good morning, and thank you, Chair. And good morning, Mr. Hodge, and thank you to you and your team for the presentation. Definitely food for thought. I have a couple of questions. Firstly, the role of the minister in the NHI. So the minister literally is this, in principle, the sole accounting officer of this entire development, this entire NHI. He gets to appoint the boards, the committees, he is literally the king of NHI, if I can put it in those terms. Now, in light of the recent Zondo report and the SIU report that was made public yesterday, and I'm going to add on to that the Digital Vibes debacle, is this not a problematic issue? Should the minister be being given these kind of powers? And will that indeed, and we've seen this happen, result in collusion, and we saw that on the Digital Vibes debacle. And if you don't agree that that is the right way to go, how would you suggest that this gets dealt with? Should the Parliament be involved in this? Should the committee be involved in interviewing committees? That's my sort of first question, and obviously it's a huge concern in light of the current situation and what we've just seen. And secondly, you've raised some issues, Mr. Hodge, where there is a kind of contradiction to the
recording stopped.
So my question to you is, will the NHI, with all of these exemptions
Recording in progress
that we have discussed today, meet constitutional muster? Because if it collides with other acts, then that must be taken into consideration. I thank you, Chair.
Honorable Hlengwa.
Thank you, Chairperson. Let me greet honorable members and the committee, the President's Competition Commission. Thank you for the presentation, a detailed one, but I have two questions on this. In your presentation, sir, you emphasize the great risk of a blanket exclusion of the Competition Act in the bill. And you propose that there are appropriate alternatives that could be considered in drafting a more appropriate exemption which protects the public internal as well. Could you provide this committee with other examples as well? Second one, could you please, on some examples of mega prohibition that Europe provides for within the healthcare sector as indicated in your presentation? Thank you, Chairperson.
Thank you very much, Chairperson. Good morning, colleagues, and let me also welcome the presentation. Just 3 questions from my side, Chairperson. The first one, the Competition Commission mentioned that the design elements of the NHI are unclear in the bill. It is general practice to have an enabling act with details contained in regulations. Do you expect that all design details to be spelled out in the act? Then the second one, Honorable Chairperson, we assume the Competition Commission are aware that this act should be read together with other legislation that is not excluded explicitly. All laws apply unless stated as such. The exemption of the Competition Act does not lead to the exemption of other laws that regulate the implementation of the Act. And the last one, how would you assume a public single purchaser and payer will be able to function under a system of free market competitiveness? What would your alternative to this be? Thank you very much, Honorable Chairperson.
Thank you very much, Chairperson. Let me first welcome the presentation. I've got one question that I want to ask the presenter. Do you acknowledge that there are other mechanisms available to address corruption, collusion, etc.? Is the Competition Act the only way to prevent a possible corruption? Thank you, Chair.
Good morning, Chair, and thank you for the presentation. I have a couple of questions to ask. Firstly, what would your suggestion be to reduce collusion across state contracts, including within healthcare? And how will you recommend to mitigate this risk, in particularly in the recent environment that we've seen that no prosecution has taken place in terms of what's been uncovered within the sector? Would you agree that the Competition Commission should form part of an oversight role as well, linking with an independent ombudsman over NHI? In what ways will the bill's registration requirements result in increasing unequal access to healthcare services? What recommendations can you provide for the bill's registration process if a member does not have a physical address? Do you feel that the bill adequately covers immigrant women in terms of healthcare access? In what way does the bill make provision for personal urgency for a person seeking healthcare? In your view, do you think the bill will result to delays in healthcare access, considering the need of adherence to referral pathways? And then finally, the MOU between the fund and the Competition Commission will be helpful to ensure a close and cooperative working relationship. Would you recommend that this is factored in within the bill? Thank you.
Thank you, Honorable Chair, and also thank you for the presentation. Just have one question. Do you consider that addressing the recommendations of the HMI where necessary can occur in parallel with the incremental implementation of NHI? Thank you.
Thank you very much, Honorable Chair. I'm sorry, my system still persists to have challenges with respect to video. The comments made by the presenter, James Hodge, on behalf of the Competition Commission, appears to suggest that low and concentrated prices are not considered acceptable under NHI. What is the Competition Commission proposal around ensuring that services offered by NHI are affordable? Is it everybody rich in South Africa to really access to healthcare system under the environment of the two-tier systems? Whether they want the status quo to remain. Lastly, are you aware about the health market inquiry presented by Minister Patel and the Commission here in Parliament about the adverse inquiry about the health market inquiry, if you remember that, by the Competition Commission? And how do you think those adverse findings should be addressed? I can go to specifics, amongst others, including the overcharge, of non-medical cost services, as outlined by health market inquiry. Lastly, Chair, it seems the presenter or the commission want universal health coverage without NHI. Is this true? Thanks.
Thank you very much, Chairperson, and thank you to our presenters today for their presentation. I think it was very important. I just want to ask, I have like three, four questions. And I want to ask what would then be like an appropriate exemption, if any, that wouldn't jeopardize what the NHI is trying to achieve. And I mean, part and parcel with this is what are the reasons for the recommendation that the blanket exemption from the Competition Act contained in the NHI bill is a concern? Is it because of vigilance against the possibilities of corruption? And if it is so, as part of the reasons, rather, can it just be overtly stated and not said, in fog or in a vague manner? Because it then becomes a very valid conversation, especially noting the submission that Section 3.5 would exempt, as part of the submission by the Competition Commission, that Section 3.5 would exempt all parties to the transaction and not just the NHIF, including private healthcare providers, pharmaceutical companies, and medical equipment. And also in this particular conversation, because I heard one of the members saying that this is not the case, and this is not what necessarily the bill or that section particularly will affect. Can Chairperson, with your guidance, can I make a recommendation that that Parliament's legal department comes to the portfolio committee and clarifies this issue of exemption, and which bills or laws or legislation it will particularly affect? Because I think it will be a grave mistake for the committee to pick up a conflict, even if it is a minor conflict of this sort, and not ensure absolute clarity on its effects during deliberations of such an important bill. So yeah, Chairperson, you'll provide guidance on that particular part, but I think we do need to hear from Parliament's legal department on which bills in particular, this particular bill, or which legislation in completion it will affect.
not necessarily those that are captured in this particular bill, but they should also investigate and research it properly, because now we're relying on interpretation of members, interpretation of people that are making submissions, and not the actual impact of what this bill could be. So please advise Chairperson on this, but that's my recommendation, that we have Parliament's legal to come and clarify us on these issues.
Honorable Siwela. Honorable Siwela.
Hey, Chairperson, thank you. Thank you very much for the opportunity. I have one question to ask the presenter. I need clarity from the presenter regarding the exemption of the NHI fund from the Competition Act. Is it the Competition Commission that the bill implies that any of the suppliers to the fund will be exempt from the Competition Act? If so, what wording will you propose to ensure that the fund can fulfill its mandate? Thank you, Chair.
Thank you very much, honorable members. Did I leave anyone out? And if not, I will also just ask two questions to Mr. Hodge and his team. The first one has to do with your very last sentence and your recommendation to the Department of Health, where you're saying that you're recommending that the Department of Health engage with and draw on the findings of the HMI as it works out the details of how the fund will function, especially given the similarities in the reforms proposed. So I'd like to hear from you whether you see these recommendations being applicable to the public health sector or to the future envisaged transformed unified national health system. And then I also want to hear from you about your proposal that the HMI recommendations be implemented in their entirety based on meeting some form of milestones for increased regulation of the private sector. What is your view about those milestones and whether such milestones be achieved to meet the timelines as stipulated under Section 57 of this draft NHI Act, taking into account competing interest in budget allocations? Mr. Hodge, I think those are all of the questions which are raised by the members of the Portfolio Committee. We look forward to your responses. Thank you.
Thank you, Chairperson. I am going to ask our Chief Legal Officer, Mr. Baki Majenge, to pick up some of the more legal questions, but maybe just to just clarify a few things that come out of the question. So I think Member Chua asked whether the reasons for the exemption is around corruption, and I think there was also a question as to whether what was the reason for objection to this from Member Siwela. So our concern is really about collusion, abuse of dominance by private healthcare providers, and that could be a broad range, which would, because of this wording, likely be brought under the exemption. And so it is not about corruption within the NHIF or the possibility of that. It's the abuse by private healthcare providers that by necessity have to contract with the NHIF as a single purchaser. So I hope that clarifies the case. And in terms of wording, our suggestion is not to include it in the bill. Our presentation makes clear that we think there are already appropriate mechanisms under the Competition Act. So were there to be elements that require some sort of some sort of exemption in the future, then they can be adequately addressed through the Competition Act. There's no need to include it in the bill. And I think even just changing the wording within the bill creates risks of this overly broad exemption compared to what we have within the Competition Act. But let me, with that, bring in my colleague, and Mr. Majenga can pick up some of the legal questions, and then I'll pick up the other remaining questions from the chair and the members.
Thank you, James. Morning, Chair, and members of Parliament. I will first start with the question posed by Honourable Member Ms. Wilson. The question was in two parts. The first part of the question related to the ministerial role in the scheme of the fund. So that issue of the ministerial role in the overall scheme of the fund is really a policy as well as a legislative issue that will really fall within the domain of both Parliament itself as well as policymakers. So that matter will be a matter that falls completely outside our domain as competition regulators. So it's really a matter for the legislature as well as policymakers. In respect of the second question relating to the constitutionality of the NHI itself, again, this again is a policy as well as a legislative issue that will have to be tested if and when it is tested. But we all know that Section 27 of the Constitution does impose an obligation on the state to take reasonable legislative and other measures within its resources to achieve the progressive realization of the right to health care. So within that context, the NHI could be seen as part of the measures to achieve this objective of universal access to health care. I think we also need to emphasize, and as pointed out by my colleague, Mr. Hodge, the Competition Commission is not opposed to the NHI. In fact, we do support the NHI. Of course, the key issue for us, as my colleague Mr. Hodge has pointed out, the key issue for us is the blanket exemption or exclusion of the Competition Act, which will, of course, lead to the kind of ramifications and unintended consequences that Mr. Hodge has referenced. The second question, which can be characterized as a question having legal implications, is the question relating to the alternative pathways to achieve an exemption of certain elements of the work of the NHI, short of a blanket exemption. And of course, as my colleague Mr. Hodge has pointed out, both in the presentation as well as in his response, there are, of course, alternatives in the Competition Act itself, mainly Section 10, of the Competition Act does make provision for the Competition Commission to grant on a case-by-case basis certain exemptions. The Competition Act has also been recently amended to make a provision for block exemptions by the Minister of the DTIC. In fact, one of the most successful exemptions that has been granted by the Commission in the healthcare sector relates to the exemption granted to the National Hospital Network, which was aimed at giving smaller hospital groups bargaining power. So there are certainly alternative pathways to ensure that certain aspects of the NHI work do enjoy some form of an exemption. I think, James, to the extent that I have missed any questions which may have some content, we can come back to those questions. Thank you.
Thank you for addressing those legal questions. Let me work through the remaining questions as I see them. So I think Member Wilson has been addressed, and then it's Honourable Singwa, which requested for some additional examples in terms of exemptions as well as merger control prohibitions within the European Union. So in terms of other exemptions that we have issued, I mean, some may stand out as maybe in parallel. So I've mentioned the National State of Disaster regulations, which sought to exempt certain coordination amongst healthcare providers, not of a price nature, but more enabling them to respond to the pandemic. So in terms of just the adequate distribution of, for instance, treatment protocols, staff to where the hotspots are in the pandemic, sharing of information around the testing volume of people with COVID and where they're located, and the ability to move staff between, for instance, clinics and hospitals in order to address. So there was elements of that, and it also included elements to allow funders to negotiate collectively to bring down the price of procurement, which has some parallels to what the NHIF intends to achieve. We've also got in other sectors of the economy, in petroleum, we have an exemption to allow some meetings and sharing of information amongst oil refineries with the minister in terms of just ensuring security of supply and to plan refinery shutdowns. So that has a broader objective of achieving a public objective of security of supply for petroleum products. So those are some examples of exemptions. In terms of merger prohibition in the EU, our written submission does provide, I think, some examples in the relevant section around paragraph 23, but there have been prohibitions of mergers. There's also been prohibitions of acquisitions by pharmaceutical companies in order to temper market power, because ultimately, as I indicated, our concern is really about the competition amongst private suppliers, which will happen under the NHIF. The NHIF is a single purchaser designed to use that and allocate resources to those that are registered and fall under the universal access. So there still will be private suppliers, and that is our concern. And if there is merger activity, then they will gain market power. And that includes global mergers for pharmaceutical companies, which remain a jurisdiction and a concern for the Competition Commission. In terms of the question by Member Sokacha, in the design elements, I mean, it's not a criticism that some of the design elements are put forward to regulations in the future, and we accept that obviously that is often in the design of legislation. But it's the fact that that is in the design of legislation, and some things will be pushed to regulations in the future, is the reason why we indicated it is better to, once those regulations are in place, and through a continued MOU with the National Health Insurance Fund, we can look at whether any exemptions are in fact required to enable the NHIF, or whether any parts of the Competition Act in particular restrict what they're trying to achieve or the manner in which they're trying to achieve it. And again, I would just cite that, our exemption process that was accelerated through the pandemic involved engagements with different parties, departments, ministers, in order to understand what the particular problem was and whether an exemption was required in order to achieve that. And where it was granted willingly. In terms of the question around, how would a single payer and buyer function under competition, it's not about this competition for a single payer or buyer that we're concerned about. We're concerned about the competition amongst the healthcare providers that would supply that single buyer. So already, for instance, within the public health system, there is a single purchaser for public health, but we still see abuse through either collusion to the public health sector or excessive pricing of medicines. And within the pandemic, there was also the opportunity for the public sector to outsource where there were capacity limitations in their own hospitals. So again, that involves a procurement process. So it's not we're objecting to that there's more than one payer, that it's more that it's a competition amongst the suppliers to the NHI. And I think that sort of addresses other questions around the focus of our concern. Then Member Geller put a question about the different methods of addressing corruption and collusion. Our focus at the Competition Commission is on the collusion element. And in terms of, if we look at the PPE procurement, we have been part of a number of institutions that have looked to address that. So we work closely with the SIU, and where there is indications of corruption, the SIU takes it forward. But where it is abuse of private sector power or collusion in the state tender, then those cases are passed to the Competition Commission to prosecute and investigate. So there are different institutions that are involved in different mechanisms. Obviously, within the state, our focus is predominantly on collusion. I think that then goes to the next member, Clark, who asked us to suggest elements that reducing collusion in state and mitigating the risk. We already undertake quite an extensive advocacy process and education process with organs of state and those involved in procurement prices in order to how to detect collusion in tenders. So either similar director names or similar address or similar pricing, similar handwriting. And we have a range of tools that we do educate and do that on an ongoing basis. And in fact, that education can be successful in times because we do get state bodies referring to us alleged collusion by suppliers on the tender. What has also happened globally is that there's a move to sort of digital detection tools where the power of big data can be used to sort of red flag, in essence, tenders that look suspicious. So this might be where the pricing is far higher for the same product than what is achieved elsewhere in government, or where there's a rotation of successful bidders for what is repeat work. So there are ways we can do that. In terms of the other question around the Competition Commission forming part of an oversight, that is, typically not our role. We have recommended a memorandum of understanding. there is no requirement that that has to sit in legislation, and we engage with memorandums of understanding with many agencies. For instance, we recently concluded one with the information regulator. So it's not required that it sit within legislation in order to take effect. In terms of some of the other design elements of the bill, we have not engaged on that. Our focus has been predominantly on the competition aspects and how it impacts on the competition. In terms of Member Harvard, I would ask that the member just repeat the question. As I understood it was around negotiations in parallel with the transition period, but I would ask that that question is repeated, and then we can certainly deal with it. I know we can do that now, Chairperson.
Thank you very much, Honorable Howard. I actually wrote down a little bit of what Honorable Howard had raised, but let's hear her repeat that question for you. Honorable Howard.
Yes, Chair.
Can you repeat your question?
Oh, okay. Let me see. Do you consider that addressing the recommendations of the HMI where necessary can occur in parallel with the incremental implementation of NHI? Thank you.
Thank you, Member Harvard, for that clarification. And I think it's also a question that goes to the Chair's question. I mean, certainly we do think that some of the recommendations can be implemented in parallel. Some of those recommendations do go to ensuring that there is more robust competition amongst private healthcare providers, which would benefit the NHI ultimately as it takes over its single payer role. Although as a single payer, there may be more bargaining power, as we indicated, the healthcare sector is highly concentrated in many areas. And if we add the risk of, as I said, exemption to that, it is, I think, addressing the structure of healthcare, private healthcare providers that may contract with the NHI is important. I mean, within that, and maybe this is to the second question of the Chair in terms of competing interests and budgets. I mean, I think we have, as the Commission, and can continue to engage on what might be a prioritization. And certainly some of the recommendations do not require necessarily public funding, but are mechanisms that also disaffect the supply side that can more implicate the suppliers themselves than the public purse. So I think that is a process where, as we indicate in our submission, it would be useful to have that engagement, and we can have a robust debate about what is a priority and what should be accelerated and what is achievable within the transition period. But even a lengthy transition period means that there will continue to be effects of private sector conduct and adverse findings in terms of cost of healthcare in the interim that could have long-term effects as well. In terms of Member Zilitsi's questions, I think it is not the position of the Commission that the alternative and the existing system is necessarily a better means of achieving universal coverage. As we indicated at the outset from the presentation, we do support the NHI and the objectives of the NHI and wish to make it a success. And that's why we feel it is important to highlight through this presentation to the committee that the current exemption poses risks to the NHI itself. It's not to be self-serving to the Competition Commission. We also want to see this as a success. And national health systems provide greater equality of access and have been successful in other parts of the world. So in terms of that, that's not our suggestion. In terms of the adverse findings made by the HMI and how they may be addressed, the HMI report does set out a series of recommendations of how to address those adverse findings. And there is also an executive summary which we can make available to the members, but it's also available on our website. And I won't go through it now because it is quite extensive, but there are quite specific recommendations to address the different adverse findings that are arisen. And that would be what we would also see as a subject of, if there is to be a discussion with the National Department of Health around prioritization and funding, it's exactly looking at that collection, I think in terms of then the chair's question on the HMI engagement, I mean, I would say, again, I think that the recommendations are quite extensive and affect both the demand and the supply side of the system through a transition, and also start to affect not just how negotiations happen in the meantime, which could be something that the NHI looks at in terms of how it regulates, and at least is some input on that, and the determination of things like PMBs. But I think as far as the recommendations go to the public sector, the HMI was targeted at private funding and the problem of high costs of private healthcare in this country. Ultimately, it has an implication for the public sector in the sense that the NHIF will take over the role of providing healthcare funding and purchasing on behalf of all citizens. And therefore, any problems in their private healthcare market in terms of suppliers and providers that will then start to impact on the public sector. In the meantime, though, some of those adverse findings do already impact on the public sector through GEMS as a scheme that does support government employees and funds government employees' healthcare. Obviously, some of the adverse elements already impact that GEMS, and if one saw NHIF as a global GEMS, then it would follow through as well. So we welcome that engagement and would welcome, trying to ensure that some of the healthcare system works better. I mean, we have learned, and this is in our impact report on some of the block exemptions we've granted, that some of the coordination, at least, and at least forums that were established during the pandemic have permitted some of the issues to be resolved, and we would welcome, I think, working with the Department of Health and even the NHIF in that transition period to identify what could be implemented even by ourselves in order to take this forward. Chairperson, I think I've covered all the questions that obviously yourself or the members can indicate if we have missed any. I'd also just like to leave an opportunity for my colleague, Mr. Majenga, to come in if there's anything he feels I've missed or points he wants to make.
Yeah, thank you, James. I think you have really covered at least most of the questions which I've noted very well. Perhaps just to re-echo the point that you made, which is to say that we don't see any contradiction between the recommendations made in the HMI report, as well as the initiative to put in place a universal healthcare system through the fund. If anything, we see the two as likely to be complementary and to reinforce each other rather than as contradictory. Thank you, James.
Thank you very much, Mr. Hodge, and your team for your presentation today. And thank you for also answering those questions of the members. We are looking forward to further engagements. Just on the question of Honorable Chirwa about getting an opinion from the Parliament's legal department, we are looking at, of course, getting some legal opinions The follow-up processes after the public hearings will also involve getting an opinion from some legal people, including the state law advisor, and we will be taking that forward. Again, if you maybe want to say a few words in closing, we will then after that move on to the Commission for Gender Equality.
Thank you, Chair. Maybe just in closing to reiterate that the Commission does support the NHI initiative and its objectives. Where there are exemptions that may be required, we are more than happy to work with and use the framework of the Act. That is probably a far more flexible and low risk option. So it doesn't deny the opportunity for exemptions to happen, but it provides it within the framework of our Act and doesn't tie our hands to address collusion, abuse, or dominance amongst private healthcare providers. So we would recommend that even in looking at the options that the exemption is pulled out of the NHI bill, and that the Commission works with the NHIF and the Department of Health to identify suitable exemptions where appropriate, as we have done in the past and will continue to do. Thank you, Chairperson.
Thank you very much. You're welcome to stay on or to leave the platform. It is a public platform, so you're very welcome to listen to the other presentations. Honorable members, we are going to receive a presentation from the Commission for Gender Equality. We will go straight into it. And we have on the platform Moeng Betlage. Inform me if I pronounce his name correctly. You're very welcome to show your face and introduce your team, and let's go straight into your presentation. Thank you.
Thank you, Chair. You have pronounced my name very well. My team, I'm with Mamelo Matthews. She is one of the legal officers here at the Commission for Gender Equality. And also we are supported by our chairperson, Ms. Tamara Matebula. Good morning to all the members and honorable members of the Parliament. I will first like to share my presentation. Just a moment so that I can share my presentation before I can proceed, Chair. Am I audible enough, Chair?
You are audible enough. We can see you and your presentation. Thank you.
Thank you, Chair. I will be going through my presentation. I will start with our introduction. The Commission for Gender Equality is an independent statutory body established in terms of the chapter. My apologies. The Commission for Gender Equality is an independent statutory body established in terms of Chapter 9 of the Constitution of the Republic of South Africa, 1996. The Commission has a mandate to promote and protect gender equality in government, civil society, and the private sector. To this end, the Commission for Gender Equality Act 39 of 1996, as amended, gives the Commission the power to monitor and evaluate policies and practices of organs of state at any levels, statutory bodies and functionaries, public bodies and authorities and private business enterprises and institutions in order to promote gender equality and make any recommendations that the Commission deems necessary. I will move on to the second slide. The Commission also has the powers to evaluate any act of Parliament, make recommendations to Parliament or any legislation with regard to any law affecting gender equality or the status of women, and may recommend to Parliament the adoption of new legislation which will promote gender equality and the status of women. The Commission welcomes the opportunity to make inputs on the National Health Insurance Bill of 2019. I will move to the contextual background, Chair. Women's reproductive health needs are different from those of men. and as such, a one-size-fits-all approach will not be desirable. When looking at this aspect, Chair, women require health services more than men. I will give an example. Women need health centers for family planning. They go there during their pregnancy period. They also go there to health centers after giving birth to get medication for their children and others. The NHI bill has the propensity to improve women's health if the best interventions are carefully assessed and costed, provided on a universal basis from the outset. In so doing, women and girls will be direct beneficiaries of the National Health Insurance once it is implemented. So, Chair, there is a need in order for the NHIB to ensure that women are prioritized in this bill. Consequent to Section 27(1) of the Constitution, women, children, lesbians, gays, bisexual, transsexual, intersexual, queer, asexual have the right to have access to health care services, including reproductive health care. It goes along with Section 9 of the Constitution, which provides for equality, and it, in short, it provides that everyone is equal before the law and has the right to equal protection and benefit of the law. And as indicated above, women requires the services of health more than men, and if they are denied the healthcare services, they will struggle more as they are primary caregivers by nature. The Commission records that Goal 3 of the United Nations 2030 Sustainable Development Goal obliges the state to ensure healthy lives and promote well-being for all at all ages. In short, health is one of the key points, Chair. If one is not healthy, he will struggle to even acquire knowledge, he will struggle even to take care of his loved or her loved ones. Some of the goals are to reduce maternal mortality, ensure universal access to sexual and reproductive health care services, including family planning, information and education, and the integration of reproductive health into national strategies and programs by 2030. Whilst the health care services are provided free of charge in South Africa, monetary cost of travel to local clinic pose a significant barrier for vulnerable segments of the population, specifically women, children, lesbians, gays, bisexual, transsexual, intersexual, queer, asexual, LGBTIQIA+, mentally disabled persons, and persons with disability, leading to overall poorer health. Women are caregivers by nature. They care for their loved ones and for their entire families. Health facilities should be easily accessible to women, and in doing that, it will lessen the burden on women to take care of their loved ones. And if healthcare services are far away from women, they will not be able to take care of their loved ones. For an example, women, they take care of the mentally disabled in rural areas. They take care of persons with disability. If the health facilities are very far away, women, they will struggle and they will have to bear the burden of traveling costs. For example, in 2016, the Commission received a complaint from a Vinkral community where it was argued that the nearest local clinic is 45 kilometers away from their community. This results into a ride being delayed because the healthcare service center is far away and is not easily accessible, and women, they cannot get the benefit of realization of their right to healthcare service. And it should be taken into account that a right denied is a right delayed is a right denied. As such, access to healthcare services was costly and further placed women to be more vulnerable to all forms of abuse, including gender-based violence. they must take care of their loved ones as well as taking care of themselves. Women, they are caregivers, and even if in a situation whereby they are victims of gender-based violence, women are supposed to be there, support those victims as they are caregivers for their entire family. From this premise, it is submitted that access to healthcare service to rural women is fundamental in realizing healthcare rights of the vulnerable groups. The Constitutional Court decision in Subramani, this Minister of Health, 1998, Volume 1, SA 765, Constitutional Court provides examination of the above aforementioned constitutional right imposed on the state to provide quality medical services to citizens. The challenge with this case is that most often women, whenever they try to access healthcare services, they come across challenges such as availability of resources. The Department of Health will inform women that due to availability of resources, they are unable to make them realize their right to healthcare services. And such, it will be deemed as the right to healthcare services is limited in terms of Section 36 of the Constitution. Focused on comments on the NHI bill, the Commission note the contents of the proposed National Health Insurance Bill. However, it would like to make recommendations to the committee as follows. Purpose and application of the Act. While the NHI seeks to promote the achievement of universal access to quality healthcare service for all in the Republic of South Africa, it fails to address existing human rights violations in the healthcare sector, such as structural violence against women and girls manifesting itself in various forms, such as refusal by healthcare workers to administer contraceptives to girls and young women, forced and coerced sterilization of human immunodeficiency virus positive women, violence against pregnant women, the elderly, and other vulnerable groups. In short, violation, it includes many aspects, such as if one cannot easily access healthcare centers, it's a violation of his rights as the state fails to provide such right. The other example, it will be the right to privacy. If one visits the rural communities, you'll find that healthcare centers, patient-doctor confidentiality is not practiced there, as the structure is too small or the structure is of container. Therefore, other people can hear what is going on inside the consultation room. And the other challenge at the rural place, it will be the issue of transportation. If healthcare centers are very far away from the community members will have to bear the cost of transportation. The NHI is written in normatively biased language using pronouns such as he or she, clearly leaving out gender non-conforming individuals who too are healthcare service users. In other words, the NHI is gender blind and is gender non-responsive. The NHI must not be gender blind, and it must include everyone as it is stated in the Constitution in terms of Section 9 and Section 27 of the Constitution. Access to care services, registration as users, the requirement for proof of habitual place of residence as stated in the NHI as a prerequisite for user registration has a potential to exclude street dwellers who by virtue of being street dwellers do not have such proof. That is in contravention with Section 9, which states that everyone has the right to equality, and Section 27, which states that everyone, it does not discriminate whether someone is a street dweller or someone has a fixed address. And that will also pose a danger in exclusion of other people, such as people who are residing at informal settlements, and those people who are residing at informal settlements, they don't have what we call allocated fiscal addresses. Therefore, it will not be easy for them to be able to have proof that they have that proof of residence and they can access healthcare centers. This requirement will further contribute to the high rates of maternal deaths, as pregnant women living in the streets could be excluded from accessing healthcare services. Even people from other places, such as rural places, they will struggle due to the fact that traditional leaders, they won't recognize them as some traditional leaders, they still practice what is called patriarchy. The above mentioned concern also applies to persons who reside in rural areas where often traditional leaders are called upon to provide proof of residence in certain complaints to the CGE. Persons such as the LGBTIQA, unmarried women, and widows often encounter obstacles and prejudice when seeking the proof of residence from the traditional leaders. Some traditional leaders will simply indicate that they only recognize men, and by so doing, they don't take into account that they are excluding women and other members of the community, and such is patriarchy, and it's against Section 9 of the Constitution. For example, the bill states that a user seeking a healthcare service purchased for his or her benefit by the fund from an accredited healthcare service provider or a health establishment must present proof of registration to that healthcare service provider or a health establishment when seeking those healthcare services. Even this Section 8 is still gender blind and is not gender responsive as it reads or as it has pronouns such as his or her. It excludes the members of the LGBTQIA+ communities. In addition, the NHI excludes persons, particularly women, who are traveling to South Africa in compliance with the Immigration Act. This one is a challenge because the Constitution it reads as everyone, and everyone it includes foreign nationals who visit, who comes to our country to look for employment. Therefore, by excluding them from the NHI, it is unfair discrimination which cannot be justified in terms of Section 36 of the Constitution. The bill does not address how much women will be assisted if they require medical attention. The NHI states that to get medical attention, the patient must be registered as a healthcare user, and to be registered, they will have to comply with the requirements of Section 5, subsection 5 of the bill, of which it is difficult for one to comply with, and the women, they will struggle as they will not have any resolution in order to be able to access the healthcare services. These groups of persons will not comply, and it is not clear from the NHI how they will access treatment and care. If they cannot be able to access healthcare services due to non-compliance, there is no remedy of where they can appeal this decision of the NHI. The reference to Promotion of Equality and Prevention of Unfair Discrimination Act 4 of 2000 under paragraph 6E is welcomed. However, the NHI fails to articulate what measures will be put in place to prevent the discrimination on all the grounds as stated by the PEPUDA. Section 6 of the PEPUDA, it states that no one can be discriminated without any justification. This is against the backdrop realization and that most vulnerable groups continue to face multiple discrimination at the healthcare services centers on the stated grounds. Example includes the life accident many tragedy, a woman tied to a chair in Mamelodi Hospital, and mentally ill patient bent in Bentworth Hospital, and others. It is fundamentally important that the monitoring and evaluation be explored in this regard to ensure the protection of human rights. Healthcare services coverage. While the NHI provides for the user to receive the healthcare services that the user is entitled to, the Commission is concerned about the multiple struggles to access gender-appropriate continuum healthcare services by the transgender persons, intersex persons, girls, women in South Africa. This section of the NHI states that for treatment must be funded if a healthcare service provider demonstrates that no medical necessity exists for the healthcare service in question. There must be a valid reason for such provision. No cost-effective intervention exists for the healthcare service as determined by a healthcare technology assessment, or the healthcare product or treatment is not included in the formula, except in circumstances where complementary list has been approved by the minister. This section has the potential to create an environment leading to denial of services and violation of human rights, given that healthcare service provision is often decided upon by other officials who often use discretion to refuse or not to recommend healthcare services for vulnerable groups such as transgender persons, intersex persons, girls, and women. If such discretion is exercised to refuse healthcare services, it is unfair. The complainant must have a way of appealing such decision, and they must first receive education on how to lodge their complaint on refusal to access such healthcare services. The NHI needs to state at least the basic tenets of the formula to avoid misuse. The current primary healthcare service package has a tendency to concentrate on women of childbearing age and exclude before and post childbearing healthcare services as a priority. In the absence of women's health policy to provide guidance, the NHI must include basic tenets women's healthcare services from cradle to grave sequence. Section 6 of the NHI, a user who is dissatisfied with these reasons for the decision contemplated in Section 5D may lodge an appeal in terms of Section 43. The issue with lodging an appeal is that in most instances, people, they require health services as on an urgent basis. Therefore, appeal, it will take long, and their right to access such services, it will be delayed and it will be denied in most instances as medical attention is required on an urgent basis. With regard to the provision above, the CGE's view is that while the NHI provides the mechanism for dissatisfied individuals to lodge an appeal in terms of Section 43, the NHI is not clear on cases when the person seeking healthcare services is incapable of making such decisions. For example, persons living with severe mental incapacity or minor children. Furthermore, the NHI states further that a user must first access healthcare service at the primary healthcare level, as the entry into the healthcare system must adhere to the referral pathways prescribed for healthcare services providers or health establishments, and is not entitled to healthcare services purchased by the fund if he or she fails to adhere to the prescribed referral pathways. The above provision is prejudicial to pregnant women who prefer to engage their regular gynecologist or obstetrician and skip a general practitioner. This will also have a negative impact on one's right to have a choice of which medical practitioner or which health care center he or she wants to visit. According to this provision, it means that the fund will not cover the cost. However, it is unclear whether the medical scheme can cover cost. Cost coverages. While this section of the bill seeks to assure the health services user that the service will be available free at the point of care, it further sets a very stringent measures under which the person seeking health services will have to pay for services a person or a user, as the case may be, must pay for healthcare services rendered directly through a voluntary medical insurance scheme or through any other private insurance scheme. If that person or a user is not entitled to healthcare services purchased by the fund in terms of the provision of this act, fails to comply with the referral pathways by a healthcare service provider or a health establishment, seeks services that are not deemed medically necessary by the benefits advisory committee, or seeks treatment that is not included in the formula. It is observed that the NHI fails to articulate what should happen in cases of emergency, and persons who face structural problems to register as users, and does not mention the basic tenets of the formula, and takes away personal agency of the person seeking healthcare services. As I've indicated above, that if one seeks medical attention, that person will be seeking medical attention on an urgent basis, and therefore it is difficult for one to follow all the necessary procedures in order to be able to have access to medical facilities, and such it will have a negative impact on the right to health. For constitution and composition of the board, the Commission knows that the proposed total of 11 board members. The Commission proposes that the composition of the 11 board members take into account consideration of diversity and be reflective of the demographics of South Africa. One should take into account that community members should be catered for, and in order for one to be able to cater for community members, it should be taken into account that the board members, the 11 board members, must be in a position to represent all the members of the community, regardless of their gender, sexual orientation, race, and it must also include persons with disability in order to ensure that they are being catered for and they are not excluded. It is submitted that a diversified board will be able to serve the interest of all South Africans, irrespective of their gender, race, or sexual orientation. Contracting unit for primary health care. A contracting unit for primary health care must be comprised of a district hospital, clinics, or community health centers, and ward-based outreach teams, and a private provider organized in horizontal networks within a specified geographical sub-district area. In terms of this provision, the Commission observes that most community care workers in South Africa are women, and it is espoused that cautionary measures must be taken when community health care workers are contracted to ensure that they are paid appropriate wages that do not undervalue their work and the contribution made by them. It should be taken into account that community members receive healthcare services from women, and in short, women, by providing such healthcare services to the community members, there must be an assurance that women, they are encouraged and they receive proper training and they receive proper motivation in order to be able to execute their duties. They must be properly trained to execute their duties, to understand applicable relevant legislation such as Sterilization Act 44 of 1998, National Healthcare Act 61 of 2003, and this, in short, it will also avoid the issues or challenges of the Department of Health receiving state claims based on medical negligence, for example. For rural residents to have access to healthcare centers, necessary and appropriate healthcare services must be available and obtainable in a timely manner. Certain factors must be considered for communities in rural areas, such as financial means of the community to pay services, and the financial means must also include transportation cost, whereby healthcare healthcare centers are far away from community members. Means to reach and use services such as transportation to healthcare centers. In many rural areas, you'll find that there is what we call shortage of transport, and a patient will be will need medical attention on an urgent basis. Therefore, such patient will not be able to access healthcare centers on an urgent basis due to lack of transport, whereby healthcare centers are far away from their communities. Lack of doctor-patient confidentiality, which often encroaches on the right to dignity and privacy of rural women. As I've indicated before, the structures of healthcare centers at the rural areas, it's not in conditions that it can provide for the right to dignity, the right to privacy, as one can hear the conversation between the doctor and the patient is sitting in another room while they are consulting. Therefore, the right to privacy will be contravened. The Commission knows that various complaints where rural women allege that nurses disclose their HIV status in the corridors. As such, most patients lose confidence in the healthcare services. That issue, it must also be addressed with education. The NHI must ensure that community members, they receive awareness campaigns or workshops or education on how to report health practitioners who goes around and breach what we call doctor-patient confidentiality. To this end, it is recommended that the NHI provides oversight of the standard of services rendered by healthcare practitioners at the rural areas. Office Health Products Procurement. Section 7, the provision of this section are subjected to public procurement laws and policies of the Republic that gives effect to the provisions of Section 217 of the Constitution, including the Preferential Procurement Policy Framework Act 5 of 2000 and the Broad-Based Black Economic Empowerment Act 53 of 2003. In line with the above provision, it should be understood that women are both consumers and providers of services. So in a nutshell, women, they must be prioritized as they are the ones who are in desperate need of healthcare services, and as they are also the ones who administer or who are most healthcare workers, and they provide such health services to the community. Therefore, the Commission submits that the procurement of health products must set aside a quota for women-owned entities to fast-track the implementation of the Preferential Procurement Policy Framework Act of 2000. In conclusion, the Commission finds that the NHI holds prospects to correct impediments hampering women's access to quality health care, including addressing women's reproductive health rights in South Africa. That will be all from our presentation, Chair. Thank you.
Thank you very much for your presentation. We have found it quite interesting, and the members would like to engage with that presentation. I have the following members who would like to raise some points with you. It would be Honorable Chirwa, Honorable Gela, Ismail, Sukacha, Avad, Munyai, Zuela. I'm going to repeat. It's Chirwa, Gela, Ismail, Sukacha, Avad, Munyai, Zuela. Thank you very much. You may start, honorable members.
Thank you very much, Chairperson, and thank you to the CGE for their presentation. On my particular side, I think they raised issues that we had raised before, and it's very refreshing to hear the same sentiments that are often missed by other people. Now, noting the issues that you have raised, which are very, very fundamental, beyond them being ideological and philosophical, they are very fundamental issues, right? Because if you are stating the issue of the referral system, the issue of infrastructure, the issue of access, because in some of the things you're noting, you're actually alluding to the fact that it's people living in cosmopolitan areas that will be most benefited by this particular bill, and not necessarily those who are living in informal settlements, who are living in townships, and especially those living in rural areas, and in particular, marginalized groups as is. So now noting all these things that exclude people, that exclude women, that exclude the LGBTQI, that exclude people with disabilities, do you then support this bill? After noting everything you've said as the Commission of Gender Equity, I want to know if these particular differences and points of conflicts are not fundamental enough for you to not support this bill, and are not necessarily fundamental enough for you to either, take a very strong point of position against or for this bill, firstly. And then number two, I'm digressing a bit, but I'm going to ask the question nonetheless because you guys are here now. Now, there's been numerous developments regarding the issue of forced sterilization that happened under the ANC government to women, Black women in particular, who were forcefully sterilized. And part of this process of trying to seek justice, the CGE played a very pivotal role. But my concern that I want to raise in this particular meeting, I want to ask, why then noting how, women were violated and how this particular act is a crime against humanity on an international level, would you then send the very same women to go collect evidence from the very people that were their perpetrators? Is it not equivalent to asking a rape victim to go and collect evidence at their place of trauma, at their place of torture, with no protection at all, but just them being told to go and fetch evidence, to go and fetch files for the CGE to do the work that it can be capacitated to do outside of that particular back and forth, and putting the lives of victims in jeopardy again, sending them to the very same places where they were harmed, to go and collect evidence? I think noting the kind of language you use in addressing women's issues, you cannot be the very same people that send HIV positive Black women who are ostracized, alienated, and tortured because of their race, because of their gender, and because of their HIV status. Then send those women to go and collect files from doctors for you to continue with investigations or to continue with this process, especially because as a Chapter 9 institution, you did not even defend your own reports, like what the public protector did with the Incremental report, by ensuring that it sees the light of day. You guys have not done that as the CGE. And in fact, if it had not been for the intervention of the EFF, this whole case would still be flat on its face, as it has been over the past years. So I just want clarity on those particular 2 points, and then I'll be fine. Thank you very much, Chairperson.
Thank you, Chairperson. Let me also welcome the presentation. I've got 2 questions that I want to ask to the presenter. It appears that you would prefer that access to healthcare services within the NHI environment is not coordinated from the primary healthcare level to higher levels of care. Are you aware that the use of a referral system will ensure cost effectiveness and long-term sustainability of the fund? My other question, under Chapter 3 of your submission, CGE appears to believe that emergency medical services are not accommodated for in the NHI bill, and in particular, the members who fall under the outside and advancy of a CGE will have no access to the EMS under NHI. I would like to point out that in reading the bill, EMS is covered in various sections of the bill, of the NHI bill, such as Section 32, subsection 2, 35, and 39, and others. My question, therefore, is what makes CGE believe that emergency medical services will not be provided to individuals falling within their constituency as alluded to under Chapter 3 of the CGE submission to this committee? Thank you, Chair.
Good morning to everyone, and thank you for your presentation. I just have a few clarity-seeking questions. My first question is, do you feel that the NHI will not be effective due to a shortage of enough healthcare workers or facilities, and it should only be implemented once enough healthcare workers are appointed and facilities, are provided? My second question, I note you're stating a lot of issues affecting the healthcare system currently. So are you suggesting that to ensure effective healthcare services are provided, it must be specified on the NHI bill or the wording of the bill? My third question, do you feel, special need patients like the life accident tragedy as an example are not effectively covered by the NHI bill? That's what I'm gathering from your presentation. How or what would you like specified in the bill to properly provide for this? My fourth question, you highlighted you highlighted that the board must be very diverse and etc. Do you feel or recommend the private sector or entities be included on the board to improve the accountability of the board and subsequently, healthcare services on the ground? And my last question, I'm gathering from your inputs on your presentation that you feel, the NHI does not allow for equal access to healthcare services, and not enough equality in healthcare services as well. So in your opinion, is this bill all-inclusive? Is it sustainable? And ultimately, would you then say that you support the NHI bill, considering all the issues you've raised in your presentation? Thank you.
Thank you very much, Chairperson. Let me also welcome the presentation. Chair, just one question from my side. The presenters seek more clarity on how the fund will prevent discrimination on all the grounds as stated by the promotion of equity and prevention of unfair discrimination act. I want that clarity. Now, my question is, you have considered the mechanism proposed in section 43, section CK, and section 6K and section 6L. Will these sections not strengthen the provision of section 6E? Then a second question, do you need further details about the mechanism proposed in in chapter 9 of the bill? That is section 42, 43, 44, and 45. Thank you very much, Chairperson.
Thank you very much, Chairperson. Just one question. Would you be satisfied with the women's health policy as the details of all these important issues can't be included in this kind of legislation? Thank you.
Honorable Siwela. Honorable Siwela.
Thank you, Chairperson. Let me also welcome the presentation. I have one question to ask CGE. Can the CGE presenter expand on the points made around Section 4 of the bill, which makes provisions for the conditions under which treatment may not be funded under NHI. CGE also seems to believe that Section 4 of the bill discriminates against the provision of health care to transgender and intersex persons, as well as girls and women. May I get some clarity with regards to which exact parts of Section 4 of the bill are seen to exclude the above mentioned categories of users? Thank you, Chair.
Thank you very much, Honorable Chair. I'm sorry that, I'm trying to drive to an area where there's a proper network. I must say, Chairperson, we appreciate the valuable input into the bill. The concern about the organization that presented before us about street dwellers is noted. Section 5 of the bill states that, open quote, when applying for registration as a user, the person concerned must provide his or her biometrics and such as other information as may be prescribed, including fingerprints, photograph, proof of habitual place or residence. Do you not perhaps think that this section can be further elaborated to cater for such circumstances in the regulation of the bill? The same applies to the travelers according to Immigration Act. Can that details not be included in other regulations? Because so far as I understand within the bill, it has been indicated that roles and functions that are not included in the bill will be covered into the regulation. You seek, that will be my, the same applies to the travelers according to them. I said those issues. So I would also want to find that from the organization, whether they are comfortable with the two-tier system to continue to persist, which really indeed it is a scientific issue that the 8% of the private medical aid schemes continue to access over 400 billion rand, which covers 16% of the population, while the rest don't have access to that money. What is their view? Thank you.
Thank you very much, honorable members. I would raise two questions with you, and I think these will be the last questions from the committee. Now, you have expressed anxiety about exclusion of medically necessary healthcare services for the LGBTQIA+. I acknowledge your anxiety about this, but I want to refer you to Section 25, which talks about the Benefits Advisory Committee, which will have representation from different stakeholders, including advocacy groups. Will this representation not highlight healthcare services for the group I had mentioned? And is it not possible that when such exclusion happens, and you have actually alluded to this, that users can follow the mechanisms outlined in Section 6E, K, and L, along with the complaints mechanism outlined in Chapter 9 of the bill? And in continuation of this, just give me a second, let me just grab my page. You're highlighting the accommodation of the LGBTQIA+ in the provisions of the bill once again refers, but I'm getting a sense that most of the comments made by yourselves do not necessarily contain recommendations in as far as the improvement of the contents of the bill in its current form is concerned. So I would like to hear from you as the presenter some recommendations on how sections 8 of the bill should read in order to reflect an inclusion of this community. Thank you very much. I think that those would be the last questions. If you can please respond to those questions, we'd very much appreciate.
Thank you, Chair. I will start with the question which was raised by Honorable Naledi Chirwa, that does CGE support the bill? From all the challenges that we see from the bill, does CGE support the bill? The CGE supports the bill. In short, the challenges, they may be cured. At this stage, is still a bill. If we have some challenges, there must be negotiations. It's not like by having challenges, we do not support the bill. We are just citing the challenges at this point. If challenges can be cured or there may be a remedy for such challenges, therefore we won't have any problem as the CGE. I will move to the second question of forced sterilization. When Honorable Naledi Chirwa indicated that isn't it wrong to send the victim to the very same perpetrator who abused the said victim? The issue of forced sterilization, I will say, is a burning issue based on so many aspects, such as, I will make an example, a complainant will come to CGE. And when such a complainant comes to CGE, she will come with information that is not full. She will say that I was forcefully sterilized, but not give the date, will not give full information on the details of which year, which hospital, when did you realize that you were forcefully sterilized. That is why in most instances, complainants, they are requested to furnish CGE with further information. It's not like CGE is saying that the complainant must go and request information from the perpetrator. We want information as CGE that can enable the CGE to be in a better position to investigate the complaint. In short, if you are given not full information or sufficient information to investigate, you will struggle when you request a copy of the complainant's medical file, because you won't have a file reference number. That's the first thing. You won't have the name of the hospital, you won't have the district, you won't have the year. And it is known that whenever you request for a medical file at the hospital, you will follow a long procedure that needs a lot of information. If you fail to produce such information when you request a medical file, therefore at a later stage you will never get such a file, and then it will defeat the purpose of your investigation, as you will not be able to come to a conclusion or a findings of what really happened before you can go ahead with such a complaint. It's not like CGE is saying that victims must go back to their perpetrators to get information. We only request additional information from the victim so that we can follow up on an investigation. I think I have managed to answer all the first part of her questions. I will go to the second questions from Honorable Gela. The question was with access to healthcare services and whether is the NHI not primarily coordinate the issues of referral and issues regarding the long-term sustainability of the fund? The referral system is important. It is noted by the CGE. The referral system is important because it assists on allocation of resources, and such allocation of resources will also support the issue of long-term sustainability of the National Health Insurance Bill. We don't have a major issue with referrals. The only issue with referrals is whereby, for example, patients is referred from a rural place to go to an urban place to meet up with a specialist. And in most instances, such patients won't have availability of resources to reach the urban areas. And that is the issue with our part on the referral system. The second question was on the emergency medical services. When we indicated that complainants or patients won't receive emergency medical services. And the honorable member indicated that it is catered for in terms of section 32. Emergency, it comes at a point whereby, for example, if there are no availability of resources, such right of receiving your or of realizing your right to health care services is denied, because when you are from a very far point, when one is from a far point to reach healthcare services, that person will never be able to realize her right to medical services. And such right, it won't be exercised due to that it was requested on an agency basis and it was not provided by the healthcare services centers. I will go to, I did not manage to capture all the questions. I think my colleagues will assist me in answering other questions. The other issue was, the other questions, they came from it's Honorable Ismail, whereby she asked that do we support the bill as the CGE? We indicated that we supported the bill. I did not manage to capture some of other questions. I will go to the question of Honorable Sokacha, when he indicated that SCGA, we submitted that the fund must prevent all discrimination. And he indicated that we must consider the mechanism in terms of section 43 and section 6. We are not saying that the fund, the bill on its entirely is discriminate. We are simply indicating that at some of the sections, they don't cater for everyone, as the Constitution indicates that everyone. So the discriminatory part, it comes into some parts whereby everyone, the word everyone in the Constitution is not applied in this bill. And the issue of us saying that is because when you say everyone, when, for example, one person goes to seek medical health services, that person will be discriminated based on his gender or sexual orientation. That is our issue with the discrimination. I will go to the other questions. Just a moment to look at my questions. I will go to Honorable Chili's questions regarding section 5 subparagraph 5. The rules which are not covered by the bill. He indicated that it is indicated that those rules will be covered in the regulations. At this point, we are trying to make the NHI bill to be in a position to cater for all the rules. We are not really saying that at this point the bill must cover everything. We are only alluding some other aspects whereby the bill did not manage to cater for. I will go to the issue of medical aid holders, whereby Honorable Chili's indicated that it only covers for 16% of the population. Our issue with the medical aid holders, we SCGE, our presentation was mainly focused on the members of the previously disadvantaged groups. Therefore, we really wanted the NHI bill to also include them whenever they provide or they want to provide services for everyone. The last questions that I've tried to capture is that one of the ones that came from you, Chair. Just a moment. Chair referred to the CGE to section 16 K and section 16L of the bill, if I'm not mistaken, just a moment. The advisory committee that will section 23, 25, and then went to section 16 of the bill. Just a moment, Chair. Section 25 provides for the benefits of the advisory committee. We SCGE, we want the advisory committee to cater for all the needs of everyone and not discriminate anyone. And we also want the bill to ensure that it does not exclude anyone in terms of the environment where those people are staying at. I'll ask one of my colleagues to answer some of the questions that I might have omitted to answer. Ms. Mello Matthews. Thank you, Chair.
Is your colleague joined?
Good morning. Good afternoon to the committee and to everyone present. If I'm not mistaken, I feel that my colleague has answered all the questions. If there are any that we may have missed, may I just ask for a reminder, please, as to questions that the committee feels has not been answered. Am I audible?
Thank you very much. Yes, you're very much audible.
Is there any questions that you feel have not been answered? Maybe just a reminder of those questions and then I can answer them to the best of my ability.
Well, I haven't particularly noted, but I think we're at the end of your presentations. I don't think I'm going to get to take another round from the members.
Okay.
Thank you very much. Let me take this opportunity to thank you, both of you, for coming today to present and to answer to any questions and concerns raised by the honorable members at this portfolio committee meeting. We are about to go to the next presenters. You are allowed to maybe give a last few concluding remarks before we move on.
I would like to make one last concluding remark. I just would like to highlight, because what I have picked up the general sense from the questions that were asked in respect of the CGE's position as it pertains to the bill and the submissions we've made. The CGE supports the bill, but the most important thing and the reason why we made the submission is that there are obviously gaps that we've identified. Whether we've identified all the gaps according to the portfolio or not, there have been gaps that are identified. And these are gaps that are incredibly important in respect of how well this piece of legislation, once it comes into effect, will work and how it will benefit us as a community as a whole. as I remember there was a question that you particularly asked, Chair, about why the reliance on Section 16 and Chapter 9 would be like why we overlook that. And I want to emphasize that we would like to solve the problems before they arise, and it would be unfair to, especially for LGBTIQA plus community, that they automatically have to rely on a complaint system. So ideally we would, if I've understood correctly, ideally we would like that the legislation be as clear as possible, be inclusive as possible, to alleviate any, let's say, exclusion from enjoying benefits of the system. And I hope that it was clear in our submission that we are in favor of the bill because it is a really incredible and important bill. However, we need to try and plug holes and make the piece of legislation as clear as possible from the outset, so that down the line, we are not running to courts to interpret certain sections because we've all interpret them differently as communities, as boards, as members of the public, in terms of civil society. And I think that's what we were trying to convey, that it would be a really good bill and it would work really well and serve the community if we address the holes in the beginning. Thank you.
Thank you very much. Honorable members, we are moving on to our last presenters for the day. We are about to receive a presentation from Solidarity. They're being led by Dr. Connie Mulder. I had noticed that he is on the platform. I'm going to give him an opportunity to introduce his team. And you are welcome, Solidarity, to do your presentation immediately after the introductions. Thank you very much.
Thank you, Chairperson. Good afternoon, ladies and gentlemen. Just one clarification, it's not Dr. Connie Mulder. I've not yet been awarded a doctorate. So unfortunately, although I take the compliment, I cannot take the title. My team that's here today is Mornay Malan is logged in, will help with any additional questions. And Anton van der Bijl, who's our legal head, might join later. From Solidarity's point of view, that's who's here today, and we're going to present. Can I just Chairperson, can I start with the presentation? We're going to have a PowerPoint up on screen, so I don't think you'll be seeing me for the vast majority of the time. All right, good afternoon, honorable members. Finally, we're in front of the NHA Portfolio Committee. It's been a long time. This bill has been it's submitted in 2019, and we're now in 2022, and we're still talking about it now. Solidarity really took serious notice of this bill, and we did some extensive research to see what is this bill going to entail and how we can facilitate this. Now, from our opinion, the bill is quite frankly, it's unaffordable, firstly, which should render all other communications and discussions about it academic, as we cannot afford as a country what is proposed in this bill. But secondly, not only is it unaffordable, it is unnecessary. And lastly, it is completely unworkable. Now, these findings we base on several experts who we contacted, as well as research we did under our own members who work in healthcare sector. We contacted Prof. Jannie Rousseau and Mike Holland. Prof. Jannie is at Wits. He's a well-known economist, to facilitate a costing of the NHI bill and to tell us what would the funding shortfall be. The reason this was necessary is because no costing had been undertaken. So when we go through Prof. Jannie's report, which is an extensive report, it's in our written submission as well, there are several key points that he makes. Now, from our perspective, this basically entails, as South Africa, as a country, we're a middle-class family who's coming to sit down at our kitchen table. We've just spent 15% more than we earn. Our credit cards are maxed, and we're now discussing whether we're going to buy a Boeing or an Airbus, because this is what the extent of NHI funding would be. Although we do need transport, this is not the way to do it, and we're so far out from being able to afford this. It's actually it's scary that we're still considering this bill. In the white paper itself in 2017, what we found is 2010 prices which have not been adjusted, and the full cost has not been added. What would NHI full implementation actually cost? For the simple reason we don't know what services will be implemented, which creates a scary slope where we can facilitate any services or none, where we don't know what the actual cost will be. From Proviani's report, we then facilitated the NHI cost estimates. We transposed it with inflation and then worked out in 2026 what would it possibly cost. And the shortfall funding, according to Proviani Rousseau, is the cost is 256 billion, and the shortfall funding would be almost 220 billion rand, which is just completely out of reach. This was in 2019. This was with conservative estimates of 2% economic growth, and with our fiscal policy not worsening drastically, meaning that South Africa's debt to GDP sort of stabilizes. It doesn't go where we ended up. In 2022, we've now been hit by the COVID pandemic. This has had devastating consequences for our economy. We've been basically subject to, instead of a 6% budget deficit, which was already unaffordable, to a 14% deficit, and we're touching debt to GDP levels of almost 90 to 100%, if you can believe the Minister of Finance. Now, this means that our fiscal situation has deteriorated radically. So if this was unaffordable in 2019, it is completely unaffordable in 2022. The funding estimates differ. Treasury stated in their midterm budget speech in 2019 that it would take a watered down version of the NHI, which would be 33 billion rand. Now, that was maybe achievable in 2019. There is no fiscal space left. As we can see, for the white paper to be successful, the white paper itself works on a 3.5% growth of GDP that needs to be established. Now, this means, quite frankly, if the economy grows 3.5%, then government's revenue should also be able to grow at least 3.5%. South Africa has not managed this in more than a decade. We've not had 3.5% growth. We haven't even touched 2% for the vast majority of the past decade. And due to COVID-19, we had a 7% contraction last year, and our recovery is not looking nearly as well. So our economy is now back to almost 2013, 2014 levels. That means what we're planning with this bill is so out of the reach of South Africa's fiscal position at the moment. There's just absolutely no way that we can afford this. And that is why we're starting with it's completely unaffordable. We cannot go through with what we've got at the moment. The funding would have to come from somewhere if we decide to continue, but unfortunately there's no fiscal space left on borrowing. We're already at almost 80% of GDP in debt. This is the South African Reserve Bank's quarterly bulletin in March that showed our debt levels. Now, the OECD recommends for an emerging market like ourselves, we should be between 30 to 50%. So we're massively over indebted already. This we can see with debt service costs being one of the items that constantly increase in our budget. So we cannot go borrow the money to implement the NHI, which leaves only one option if we decide to continue with this completely unaffordable bill, and that is we need to tax citizens more. We need to lift our taxation. Now, this could take several forms. Prof. Rousseau's recommendations are either an income tax surcharge of 20% to fund the shortfall, a VAT increase from 15 to 20%, so a 5% VAT increase, a payroll tax of 5.5%, or increasing corporate tax, or a combination of all of these. Now, all of these have massive implications. As you can see, South Africa is already, for an upper middle income country, as the OECD defines us, one of the most heavily taxed countries. We're taxed like a first world country, but we do not have the economy of those countries, which means the tax burden in South Africa is significant. The tax base is very small, unfortunately, and there is not a lot of room. All indications are that we've already reached the Laffer curve. This we can see with tax buoyancy, and if reports are correct, we've seen a massive decrease in taxpayers and in tax from this year onward, which means our option for funding this with higher taxation is not looking at all possible. These are massive amounts of tax that would have to be levied. So we calculated for our members, if you use the 5.5% payroll tax, which is the preferred option, a payroll tax to some extent, to fund the funding shortfall, this would be the average taxation with the NHI for our members between these income brackets. The income brackets are allocated to match the SARS's tax brackets. So if you're earning between 7,276 Rand and 18,017 Rand per month, if we use a 5.5% payroll surcharge tax to fund the NHI, your tax would increase by 105%. If you're between 18,000 to 28,000, that would be 37.7%. And it, as you can see, it increases significantly as you continue with, ultimately, even at the top bracket, if you're earning more than 138,000 Rand a month, you would see a tax increase of about 14.6% to be able to fund the
Mr.
NHI.
Mulder, can
Yes.
I just quickly interject? Can you put your slides actually projected onto the screen and not on the side there? If you click on your slides.
Yes, all right. Let me just go back. All right, let me stop the share. Is it not showing for everyone?
Well, you still had it not enhanced on the side.
All right, sorry. Share. Now better or not?
No, it's not. If you go to your left, which slide number are you on now?
I am on slide 6.
There we go.
All right. Is it? Can I just do it like that? If I do presenting, it's
Do that, or you can use your up and down or your down arrows to move the
all
slide.
right. No problem, Chairperson. As this is better with visibility.
Much better, thank you.
All right. This is okay. So we're back to these are our calculations based on the vast majority of our members, like 75% earn between 7,200 and 30,900, 38,900. So our members would see a significant tax increase just to be able to afford the NHI, if at all possible. From our perspective, this is not something that South Africa can afford. We're considering literally we don't have money for food, and we're trying to buy an aircraft. The second part of not only is it unaffordable, but it's completely unnecessary. The findings that the NHI or the proposals are not the ones necessary to actually facilitate the change that we necessary. Now we need to understand Solidarity is not of the position that healthcare is at a good place at the moment. South Africa's healthcare is in dire need of reform. We cannot keep the status quo, but we don't think the NHI is the way to reform this. This would be equivalent to having a leak in your roof in the kitchen, and then your answer is to bulldoze the whole house and rather build a mansion. So if we go back to our metaphor, we're a middle-class family, low upper middle class according to the OECD, and we're spending 15% more than we earn every month. And we've got a car that we need, but this car has several problems. Now, the logical thing would be to rather fix the car. And this is what Prof. Alex van den Heever, who we commissioned for a report in 2019 to specifically focus on the NHI bill, came to. His findings were quite thorough. The report is attached in our written submission as well. And it says, number one, the NHI is not thought through. There are so many more ramifications that would happen if you completely dismantle private healthcare, especially on the funding side. Extensive mention is made of the fact that we are going for pooling and purchasing split when there's not a lot of evidence that shows that purchasing is the problem at the moment in healthcare. It's much rather governance that we've got a problem with. And that's why it says every single rational or every single policy proposal that has been proposed as fixing a problem does not come with evidence. It doesn't come with feasibility studies. It doesn't come with concrete reports that show this is what we need to do to fix public healthcare. From our perspective, that means that this is not a rational policy. We're trying to, in short, solve a problem. NHI is a solution looking for a problem. And the problems that we have in healthcare, which we do, can be fixed much easier than completely changing the whole healthcare sector, completely changing the way healthcare is done. Not the fact that almost no feasibility studies were done on such an extensive policy is very worrying. And then this does pose a significant risk to the existing medical structure. What we're talking about is if the bill goes through, that private medical schemes and private insurance would basically be relegated to only products that the fund does not explicitly offer. This would be a dismantling of the private medical scheme situation at the moment, without showing that there would be significant benefit to the members on those private medical schemes, but even to the bigger public, the idea that suddenly the whole public would have access to private healthcare and that everything would become South Africa's private healthcare is just not something that we can see. We would like that. We would obviously like public healthcare to be better, but we do not see this happening with the NHI. The last thing is then that it just misdiagnoses the problems in public healthcare at the moment. There are several problems, but purchasing is not necessarily one of them. And going for the complete reversal with pooling and provider purchases split as necessary as NHI suggests is not going to fix the governance problems. In fact, it might increase it. And this is the last recommendation or finding of Prof. Alex van den Heever from WITS. He says, there are much easier and much more viable reforms, as illustrated, that should be followed. And we concur. There are a lot of things that we can do before we get to a situation where we decide we need to scrap the whole system almost and start over. The first thing that in table 10, it's page 75 of our written submission of Prof. van den Heever's report. He goes through the problems specified in the NHI bill, and then how in the white papers and the NHI bill, and how the actual NHI bill addresses these problems. And as you can see, for the two-tier system, it just does not address the pooling maybe, but it doesn't address the rest. There's no evidence provided that this would increase the quality of care, that it would decrease the quadruple burden of disease, social determinants of health. It cannot find that it would, maybe private health sector cost would come down, but there's nothing that shows that the main things that we've identified, that he's identified as problems with the public health sector, with the health sector in South Africa, that these would be addressed by the NHI bill, which shows a misdiagnosis of the actual problems, and and then taking such extreme steps is extremely worrying if we're not talking about what we should actually be doing. The irony of universal health coverage, which is what the NHI bill is purported to be, is that the International Labour Office did a gap analysis on South Africa and basically came to the conclusion we've already got universal health coverage to a large extent. When we're talking about the gaps that exist in legal health coverage, South Africa is shown to not have a gap there. In financial deficit, most of the population, well, all of the population does have access to free medical care according to a means test if necessary at some point. So there are what exactly the NHI is trying to address here is not quite sure. What this looks like is we've got a system that can work, but there are serious issues in the system, and we should much rather be addressing those issues than specifically focusing on revamping the whole system or completely trying to rework something that can work if we just fix governance a bit. And this is where Prof. van den Heever extensively stands still and says the main problem in South African hospitals, quite frankly, in public hospitals, is we've got a governance failure that gets back to extreme problems with service delivery. And he explicitly says political appointees have caused massive issues. And then having a fund that states that we will now have all healthcare done by political appointees, well, not done, but the purchasing and political appointees would be a part of the fund's setup. This is something that worries us immensely. If you look at just the Auditor General's findings on health departments, the fact that only the Western Cape managed in the 2018 report an 82% clean audit in the healthcare, with Gauteng's second at 52%, a distant second, and then after that is Mpumalanga at 24% clean audits, and no one else really got above that. So we're looking at 5% and 8% clean audits. There's a lot that can be fixed before we try to scrap the system and start over. And we should rather be focusing on those reforms that have been recommended by the NHI Committee in 2005, by the Taylor Committee, by the the National Department of Health's consultation document, by the Ministerial Task Team in 2005, and by the most recent health market inquiry of the Competition Commission in 2019, which diagnosed the problems in healthcare, which there are, but came to the conclusion that not only you should not go to a single payer scheme or a monopoly purchaser, but you should have more schemes and allow risk adjustment to enable and then maybe move eventually to get universal health coverage to mandatory participation in a scheme, but not have only one scheme, and to ensure that we can get health coverage done whilst still competing efficiently. None of these came to the conclusion that we need a single purchaser, a monopoly purchaser, or that it would drive prices down. In fact, they came to the conclusion there are several issues, and most of them are governance related. The last objection we have to this bill is we don't think it's workable. It is completely unworkable. This would be our middle class family now deciding that we're going to fix the car, but we're finding out after we fixed our car, or well, after we've bought our Boeing, which is what we're proposing, there are no pilots left, and now we're also stranded. We cannot go anywhere. Solidarity did 3 different surveys amongst healthcare professionals who are members of us, 1,410 answered, just asking what is your general opinion of the NHI, and overwhelmingly, this opinion is negative. It's almost 4 out of 5 that have a negative opinion. Other answers would be, we're not sure what's going to change, but the most significant one is, quite frankly, 85% of healthcare professionals agree that the implementation of the NHI will lead to private healthcare professionals leaving the country. So that means they're completely convinced their colleagues will leave the healthcare sector, either the sector or the country, if this were to be implemented. Now, this smacks of not having consulted with the people who need to drive this system, and them being extremely unsure, and finally them then deciding, I'm going to do something else. The certificate of need that recently came up has been the start of. We did some research on our members regarding that as well, and it's overwhelmingly negative, with several expressing that I will personally leave. And this is the next one that says, because of the proposed NHI, I have already taken steps to emigrate. It's 13.7%. But then when you say when it gets implemented, almost 36% of respondents say, yes, I'm going to emigrate then. I'm going to leave the country. Now, this is leaving the country. That's extreme. Leaving the profession, let's say people talk a lot, but leaving the profession should be somewhere along those lines, which should be extremely worrying. If we're talking about providing better healthcare and better access, then we need healthcare workers who actually are able to work in the system. And at the moment, the sentiment amongst healthcare workers is to such an extent, they're just going to not do it. So it's all of this uncertainty that we've captured in this bill, but we haven't communicated with the people on the ground who are going to have to implement it, and they are extremely negative about the system, and quite frankly, they're going to leave when it happens. This is that's just the audit finding. So from our perspective, we're not of the opinion that healthcare in South Africa is at a good space. We need to reform healthcare in South Africa. The current situation is not sustainable. However, we cannot implement a system that would detract from what is currently available on offer, which means we cannot have a system that dismantles private healthcare for a benefit that we cannot see proven in any evidence or any studies, any feasibility studies on the public sector. We think the public sector needs to be fixed, most definitely. We think there are several things that can be done, and we think we need to start with cleaning up governance in the public sector. And this we can see through the simple fact that in the Western Cape, for some reason, public health seems to still be working, but in a socially sort of identical province like Gauteng, you've got significant challenges with public health. And this implies that it's a governance and a management problem, much rather than anything else. The NHI misdiagnoses this. It is completely unaffordable, which actually makes most of the discussion academic. South Africa just simply cannot afford what we're proposing here. We want to honestly buy an Airbus when we cannot even afford a car. It's completely it's unnecessary. At the moment, we've got a health sector that does to a large extent can do what we need for universal health coverage. We just need to fix the obvious leaks in the roof, and that it's unworkable. We've not consulted with healthcare workers, and we haven't considered the impact that this system would have on healthcare workers who will inevitably leave the country. So from our perspective, we cannot support this bill. We're not going to. In fact, we feel so strongly that if this bill were to continue, we are most definitely looking at instigating litigation against it to get a more rational approach to healthcare reform.
Thank you, Mr. Mulder. So on that note, we now know what we are looking forward to with regards to the actions from your side. We have a number of members who want to raise some questions from you. Honorables Van Staden, Sokacha, Yela, Clark, and any other members. Let me just...
Suela.
On our chat group here, Siwela. The rest of you may shout your names, or if I can get to there. So, Munyai, Siwela, Munyai, Harvard, Wilson, and thank you very much. And then Honorable Klangwa says she's still not feeling too well, so she will not raise questions now. We wish you a quick recovery from the flu, Klangwa. I will repeat then. It's Van Staden, Sukacha, Gela, Clark, Siwela, Munyai, Harvard, and Wilson. In that order. Thank you, members.
Thank you, Chairperson. Good afternoon, Mr. Mulder. Thank you very much for your presentation. I think you have provided us today with information that we have as a committee needed to know in order for us to going forward. So thank you for that. I just have one or two questions for you. My question is, and it's very straightforward and simple. Well, are you able to provide this committee and Parliament with an alternative model that is and that will be better than the National Health Insurance in order to provide extremely good healthcare to all South Africans, and that is affordable for our South African economy? Thank you, Chairperson. That is all from my side. Thank you very much. Thank you, Mr. Mulder.
Thank you very much, Chairperson. Just two questions from my side. The first one, the presenter is dismissing the evidence on the on the quadruple burden of disease and social determinants cited in the NHI document bill. Now, my question is, are you saying you do not agree with the MRC, the NICD, the HSRC, and the WHO survey on the burden of disease and its impact on health systems? Then, Honorable Chairperson, my second question is the evidence relied on in the solidarity slides seems to be purposively selected to present a negative argument towards the NHI with no specific reference to elements in the bill. Are there any specific consideration or comments on the NHI bill, or is the position that solidarity doesn't support the universal health coverage, so there's no need for the bill? Thank you very much, Chair.
Thank you, Chair, for the opportunity. I've got two questions to ask to the presenter. My first question, Chairperson, the goal of NHI is to extend population coverage, improve the quality and quantity of service available for the population whilst deepening financial risk protection for all, not just consumers of private healthcare. Have you read Section 2 of the bill, which states the purpose of the NHI fund? My second question, Chairperson, did Solidarity submit comments on the green and white papers on NHI when the NDOH had published them for comments and input from the stakeholders? Thank you very much, Chairperson.
Honorable Chair, thank you very much for this opportunity. I want to ask Solidarity, for instance, they pointed out the NHI has been not thought through. Are they disagreeing with all technical analysis outlined in all policy documents, including the bill? You have also argued that there's no evidence on the public purpose of the NHI. my understanding of the public purpose is that it means all purposes benefiting everyone, not just private individuals. Have we noted from the technical analysis presented to us by a different stakeholder how inequitable, inefficient, and discriminatory the current system is? Are you saying that this does not demonstrate the evidence of the public purpose? Should we allow the current status quo to continue with the two-tier system, of which the private medical aid or private sector receive 8% to the GDP, accounting to over 400 billion rand? Do you want that to persist? What about right to health care? What about right to equitable for everyone to have access to services? I continue to say, for instance, I was involved in car accident with my brother. Now, please, Chairperson, can you protect me from this perpetual disruption by honorable member who doesn't follow the rules?
You are protected, Honorable Munyai.
Honorable Chair, I
My
repeat.
apologies, Chair. I did not realize I was unmuted.
Okay. Honorable Chair, I was involved in the car accident with my brother. I have medical aid from Parliament. He didn't have medical aid. He was not picked up, and he was terribly injured. He was not picked up on the basis that of his socio-economic status. He didn't have the money to pay. I have medical aid. They wanted to pick me up. I said no to hell. I can't leave my brothers in a very injured status like this. But the ambulance left him. The ambulance discriminated him by leaving him there under very dire situation. Is that what you want to see perpetual? Connie Mulder from the Solidarity, as I believe, if I can be answered.
Chair, thank you. Can I go ahead? Because I was supposed to go forth, but it doesn't matter. It's not a problem. Thank you, Chair. Thank you, Chair. I would just like to ask the following questions, please. How would you say we will be able to provide universal health care in this country, considering the feasibility of the state and to incorporate the private healthcare system as key role players? It's critical that we achieve such to provide quality healthcare to all South Africans in this country. You talk about most South Africans having access, but we all know that the current system has really failed healthcare in this country, you know, and that we are not in a situation where we provide quality healthcare, and that is something that we really need to look in turning around. And as my previous colleague, Member van Staden, had said, it would be very interesting to see an alternative model in order to achieve this from yourselves. I also would like to ask you, in terms of the healthcare profession, what would you say government should do to ensure healthcare workers are brought into the fold and that they have the opportunity to participate in terms of the proposed bill, and that their inputs are taken into account? Because I think that's a very, very important aspect, because they will be playing an absolute key role in terms of providing services. And I mean, if this has been missing in terms of the public participation, then certainly that's an aspect that really needs to be looked at. Thank you.
Chairperson, is it my turn?
It is your turn, Honorable Sibela.
Thank you, Chair. I would like to ask the following question to the presenter. The presenter indicates that NHI is unaffordable and hence any further discussion is academic.
And this is based on selectively chosen analysis to suit this position. Is Solidarity aware that NHI funding is not based on introducing new taxes, but more about the restructuring current allocations into the health sector? Secondly, Solidarity also indicates that NHI is unworkable because of the findings from their study with 1,410 respondents who are mainly or primarily members of Solidarity. Is the expectation that a policy that yields benefits to a population of 50 million plus lives must be accepted or rejected based on the opinions of 1,410 individuals? Thank you, Chair.
Thank you, Chairperson, and I hope that I am next because I've kind of lost count along the way. Chair, thank you very much to Solidarity for your presentation. I have a couple of questions. The first is that what is universal health coverage? Well, universal health coverage allows for any person, any citizen of South Africa and foreign nationals, according to the WHO, to access health facilities to get medical care when required. Now, principally, my argument in this case is that in actual fact, we do have universal health coverage. There is nothing in this country whatsoever stopping any person going to any clinic or even hospital to access medical care. They've never been stopped, they're not being turned away, and they are being dealt with, although under very, very difficult conditions. We had a comment by earlier presenters this week that the entire health system must be based on 3 pillars. One is the affordability and sustainability of the health sector. The second is accessibility to health. And the third, of course, is quality. Now, in principle, if you have a look at the current health system, none of those pillars are really in place. Therefore, we have started already on a very rocky foundation. But it does not mean that South Africans or those other people in the country requiring healthcare cannot go to a facility and are turned away at any facility. So in principle, we basically have a universal health system. I'm not sure if you would agree with me, and therefore should the priority not be to upgrading those systems, putting in a solid foundation, and then starting with a slow implementation. For me, and I'm not sure if you will agree, that should be our priority. You did mention the report by Professor Alex van der Heever. I'm not sure if I have got that report. I've struggled with my system. I just ask our secretary while she's on the platform to please ensure that we get that, because I think it's a very extensive report. In terms of the first Zondo Commission report, and I'm going to link this to the current SIU report on the horrific corruption and collusion we have seen with regards to PPE and the corruption and theft that took place in this country as a result of that. It takes me to our single purchaser system. And particularly with one person being accountable, and that being the minister, i.e. the minister has got the sole responsibility of appointing boards, of appointing officials, and you know, I have an issue with that. Could you expand on your concerns about the minister having the sole right to manage all of these things? And will it not lead to collusion and corruption in the long run? It must certainly affect pricing. And a big concern is, and you can tell me if you agree or disagree with me, that system is going to stop innovation and development in the health sector, because why should one do that if they're never going to be considered, or their innovations and developments are not going to be considered because of the single purchasing model? And lastly, if you can tell me that in your opinion, Will this bill, if taken to the Constitutional Court, with all its problems, and we have heard dozens, many repeated in the presentations over the last few months, if you believe that this bill will meet constitutional muster? Thank you very much.
Thank you, Honorable Chair. Also, thank you the presentation. I just have two questions. First one, what about the Constitution? Does Solidarity reject the right of access to health care for all, as provided for in Section 27? How does Solidarity propose that we should fix the health system, since you are not convinced that NHI is feasible? We have heard a lot of mention of various professors that says it is unaffordable. Second question, has Solidarity any work of their own to come up with the views presented today? I thank you.
Chair, may I go now?
Yes, Honorable Ismail, I've indicated to you that you can ask questions. Thank you.
Thank you, Chair, and thank you to Solidarity for your presentation. You know, it's good to know and it's good to hear from all entities and all stakeholders to be able to actually get a rounded view on this matter. So what I would like to highlight and ask again, although it has been asked, I think, before by my colleagues that have spoken previously, however, I think it must be stressed. I would like to really get your input on, alternatives. And, while I agree that, you may say, or it may be understood that, we already have a healthcare system in place. We also know that this healthcare system is not actually viable. It's not working in South Africa. We have public public hospitals, public clinics, we have everything. However, to our detriment, we have so much corruption in the system, for one. Secondly, we agree that, we're not actually getting efficient healthcare services to our communities. Now, what do you think is an alternative to the NHI could be put in place, considering the fact that, we've got healthcare workers. We've got healthcare workers that study overseas, that are South Africans, but they are forced to go overseas to study simply because they're not getting the opportunity for studying in this country. We have the fact that, we have community service doctors that are waiting to be placed, although there are openings in our hospitals, but due to lack of funding. We have nurses that are crying to say that, their contracts have now been, terminated after this COVID, pandemic, or rather, I should say it's coming to an endemic now. So the needs are much lower according to reports that we've received. But we all know that nurses are crucial in all our facilities. Now, considering the fact that we've got healthcare workers, that are not being placed. We know that healthcare workers are looking at going overseas because they just feel that, they're not getting value for money, for one, and two is that they're not getting opportunity, frankly. So what do you think? And let me not even go much further on the infrastructure that we have issues on, and we do know that, there is a lack of funding, et cetera, but I mean, what would you recommend as an alternative? I mean, have you done a feasibility study, as stated before by, I think, one or two of my colleagues, to say, what can you actually recommend to be placed on the table so that the National Department of Health with Treasury can look at as an alternative, taking into consideration medical aids, taking into consideration the private sector, and where we can actually put things on the table that will make our healthcare system in our country work, with the ultimate aim, and the crucial aim, I should say, of providing universal quality healthcare to our people of South Africa. Now, why I'm highlighting this is because everything that you're saying on your financial, feasibility studies makes a lot of sense. And the fact that we've already got a healthcare system in this country, we don't want to, reinvent the wheel. So I'm just suggesting that maybe you could write in, submit your recommendations or inputs to say, where you have this on the bill, substitute it with A, B, C, D, E, so that what we have can actually function. Something of that sort, so that we can actually progress instead of regress by going to reinvent the wheel, and by while you do with your inputs, we can actually look at all other submissions to say, what, where are the shortfalls, and let's make it work in this country where we have an efficient healthcare system. Thank you, Chair.
Thank you very much, honorable members. I'm not going to allow another round from the members now, so I'm going to pose all the questions which I want to pose, and I want to speak to a number of issues, Mr. Mulder, which you had raised on behalf of Solidarity. The one is that you talk about the fact that no research or technical analysis have been undertaken to support the statement that the current two-tier system is inequitable. I find it very challenging that you would make such a statement, since we are fully aware of the financing and benefit incidence analysis included in the white paper. Now, the conclusion with regards to this in that white paper is that the benefit incidence of health care in South Africa is very pro-rich, with the richest 20% of the population receiving 36% of total benefits, despite having a health need share of less than 10%. While the poorest 20% receive only 12.5% of the benefits, despite having a health need share of more than 25%. Do you disagree with this analysis, therefore? And if you do, what is the basis of your disagreement? Have you done your own financing and benefit incident analysis? And if you have, you can please share that report with us. And then on your talks about the risk adjustment mechanisms, are you proposing that the current dual healthcare system should be maintained with all its challenges? The Parliament should rather focus on equalizing risk factors for the medical schemes population in isolation of the poor, and strengthen cross-subsidization and social solidarity for the private sector. If that is so, what would then happen to the poor people? Would that not defeat the objectives of social solidarity, therefore? And then you also admit that your judgment of the system is based on your particular ideology and your interpretation, or rather I should ask you, do you admit? I can't say that you have admitted. But it's based on your particular ideology, and your interpretation is based on your own interests that are not necessarily the interests of the majority of the poor people of South Africa, or the people of South Africa for that matter. If you could tell us about your views of the ethics of the bill. And then two more points I want to raise with you. One is regards to your comparison of the 33 billion rand and the 226 billion rand calculated, and your calculation of the NHI implementation shortfall in funding on the basis of these figures. Now, where is the data, and what are your data sources that you used to arrive at the 226 billion rand and exactly what is covered in this figure? And then finally, in your closing comment you mentioned that solidarity seems to be threatening legal challenge, and you would remember that I actually mentioned this once you had made that statement. So the question would be, should we as Parliament therefore continue the processing of reviewing the NHI bill? And am I making a correct conclusion? Thank you very much. Those are all the questions from the honorable members, and you are very welcome to respond to those questions. Thank you.
Thank you, Chair. There are a lot of questions, so bear with me. I've got several papers here written. I think we can start with Honorable Sokucha, who says that we're just plain dismissing evidence, and do we not agree that the burden of disease is a problem with several other institutions. Now, I think we explicitly stated, and it's actually quite worrying that members still did not get that. We explicitly stated that we are not happy with the status quo. We think healthcare needs reform. We don't think the system as it is one that is sustainable on the long term. We, however, vehemently disagree with the NHI as the solution to this problem. We think, quite frankly, that this bill is solving a lot of problems, but those are not the problems that we have. So obviously the burden of disease is a problem that healthcare experiences. This would be folly to say that when people get more sick, healthcare is not more taxed. However, stating that the answer to this is a single fund with a monopoly purchaser that destroys private healthcare whilst having negligible, from what we can tell, benefit for the public healthcare sector, we don't agree with that part, of course not. And we don't think that's going to work. And we think, quite frankly, it's going to have the opposite effect. We're going to have negative health benefits in South Africa, and we're going to reduce the health benefits that we've already had. Then Honorable Silitsi, firstly, I'm truly sorry for your motor vehicle accident. It's never fun to be in a motor vehicle accident, and I hope that you recovered and that your brother is also quite fine. However, we we obviously do not want a situation where ambulances drive away from someone because of their socioeconomic status. The fact of the matter is that there was an ambulance there, and that ambulance should have picked up your brother, but that's not. Once again, the question is, would NHI be the correct way, or should we rather look at reforming our current health sector, or at least changing the way the public health sector works at the moment? For the simple reason, we've got massive issues in public health care. There we agree with you 100%. We don't want that to persist. We think we can fix that. We've got primarily governance issues, and as Honorable Wilson stated, extensive corruption issues. Now, this should not be something that should be difficult to fix. It's simple. Get rid of the people who steal, and then once we've done that, then we can see what does the sector look like when it's actually functioning. We've got an example of this in the Western Cape, where the outcomes are much better. As Prof. Van den Heever states in his report, Gauteng, with a very similar social makeup of the Western Cape, has significantly worse outcomes. So it's not funding, it's not purchasing, it's a governance and a management problem that we've explicitly seen. Do we think the current health system is discriminatory? Do we want the whole 8% of GDP is being spent on the private sector? The catch there is it's 8% of GDP, but it's that this is private money. So that the question would be, why do people need this amount of private money? This is not tax money. This is something that people spend on top of tax money. There's a tax credit that gets specifically regarding healthcare. But from our perspective, we would like public healthcare to be better. We would obviously like public healthcare to be better. We think the way to do it is to first reform the system that we currently have. This is a much cheaper alternative, and it's much more viable than proposing a bill that would invalidate private healthcare to a large degree, and then have no, from what we can tell, negligible benefit for the public health sector, just reducing the current offering rather than adding to the current offering. And our perspective is we need to add to the current offering. We can do that. It's much more viable than changing everything. As we've stated, just because your roof is leaking does not mean you should bulldoze your whole house. You should fix the leaky roof, and that is where we should start. This current bill envisages a complete rehaul of a system that is not necessary. Then let's go. Honorable Van Staden asked for an alternative model. Prof. Van den Heever extensively deals with this in his report, in which he states, well, firstly, the health market inquiry of the Competition Commission in 2019 also did an extensive diagnostic on the health sector. Identified a lot of the same problems that the NHI bill identifies, but comes to radically different conclusions. Ultimately, they state that they would propose that we get more medical schemes, we get more purchases to drive efficiency and costs down, and then they're looking at, in the longer term, having a mandatory medical aid membership and forcing medical aids to then have a very low base entry level. So then you would have competition amongst purchases as well. You would have competition that automatically drives prices down, and you would have the market working to get that going, whilst then enabling universal medical aid membership. This would sidestep the massive problems that we've seen with central funds, with central funds that is available for plunder. Unfortunately, in South Africa, this is a reality that we need to face, is when there's a central fund, a certain portion of that will most likely be lost to corruption. We've seen this time and again. We can sidestep that if we follow the health market inquiries attempts or models that they've implemented, that they've stated. So that would be one of the findings that we think we should be addressing. There are several more that they've done. Prof. Nhi has done extensive work on what could be more viable alternatives. This is in our written submission that we submitted in 2019. I can read from it, but I don't think we have enough time to read extensively from it. But the findings are, in short, that corruption is a massive problem, and we'll be in trouble there. Then let's go to Honorable Gela. I hope I'm pronouncing it correctly, which states, do we not want to extend coverage of healthcare to the broader population? Once again, we've stated our position extensively. Yes, of course, we want healthcare. We want people to have access to healthcare. As Honorable Wilson mentioned, at the moment, we have that in South Africa. It's just poor quality healthcare. We think we should much rather be addressing the poor quality of the healthcare in the public sector than trying to change the private sector. So from our perspective, yes, of course, we need to ensure that the quality in the public sector gets better. We think there are a lot of different ways of doing this. We don't think this bill that completely changes the whole legislative framework is the way to do it. We don't think a single monopoly purchaser will achieve this goal of increasing healthcare. The Constitution guarantees access to healthcare, and arguably South Africa already has that. From our perspective, having access to poor quality healthcare is not a realization of that right necessarily, which means you need access to good quality healthcare, but that can be achieved by reforming the public sector, by first getting to a point where our health departments and hospitals get clean audits. It's literally as simple as that. The moment we get to a point where our hospitals have clean audits, where we've got good governance in every single public hospital, if we're at that point and we decide we're still not satisfied with the health coverage we have, then we can start having this debate about reforming the system. But just because the system doesn't work at the moment doesn't mean we need to change the whole system. It's much easier and much cheaper to just get rid of the crooks. It is literally as simple as that. Did we read section 2 of the bill? Yes, we read these bills extensively. We read all the white papers. We commented on the 2017 white paper. On the 2011 green paper, I would not be able to say. I'm of the opinion that we would have, but I was not employed with Solidarity at that point. Do take it into account. This is 11 years ago. On the 2017 white paper, we most definitely commented, and the 2019 bill, we most definitely gave a written submission. In fact, we had to go to court to be able to give an oral submission to this committee. So we've been in part of this process extensively from the start, and we're participating in the legislative process, and we're thankful for the opportunity to then present our findings. For Honorable Siwela said that we've selectively chosen our data and to show that it's unaffordable. The data that we chose is from National Treasury's budget. So we selectively chose the ones that are well relevant to funding something with debt to GDP ratios. But this is public knowledge that South Africa is not in a good space, fiscally or economically. And just stating that does not imply that this would be that we've now cherry-picked the economic data specifically. Restructuring that, the bill itself states explicitly that they would be funding it through taxation. We've just simply contracted Prof. Rousseau in to tell us what would be the impact of this taxation. And he then used the 2017 white paper with the proposals that they proposed, used their values, adjusted them from 2010, which was not done. This is something that needs to be stated. It wasn't inflation adjusted the values in the 2017 white paper, it was 2010 values. He adjusted it for inflation. He adjusted it for inflation further to 2026, then worked out what percentage of our GDP we would like to spend on healthcare, and then worked out the funding shortfall. So this is not something that we've tried with black magic or something along those lines to get. This is public knowledge. It's the Treasury. It's public knowledge of South Africa's finances. South Africa is in a very, very dire situation financially. This should not be a controversial opinion. The fact that we do not have money to afford this is not something that we're making up. This is a simple fact. And this means, from our perspective, Prof. Rousseau just did a simple, how would we be able to fund this? The one is a 5.5% surcharge on payroll taxes, which has been stated as the preferred benefit option. And we then took that number that is in the 27 white paper and in the 2019 NHI, in Prof. Rousseau's statement, but according to the 2019 NHI Bill's values in the 2017 white papers bill, and worked out what would be the impact on our members if you have a 5.5% surcharge. Then regarding for Honorable Siwela, who said it's unworkable because we had 1,410 healthcare workers, which we surveyed, that this would not be for 50 million people. The harsh reality of surveys is you cannot survey 50 million people every time. And it's not like 20 or people, 1,410 is a very good sample. This is also not the general population. These are healthcare workers that work for, that are members of Solidarity. So we explicitly targeted the ones who should be implementing the health reforms, who would be working in this system. And having a survey of 1,400, it's not absolute, obviously, but the margin of error would be actually quite small. And it's an indication for how healthcare workers in general would feel, especially, well, it's an indication for how healthcare workers who are a member of Solidarity feel regarding the system. And from our perspective, it's a valid survey. Honorable Wilson stated that universal healthcare coverage already exists. We concur. Is if you look at access to healthcare, South Africa does have access to healthcare. It's not access to good quality healthcare, but that does not mean that we're failing in universal healthcare coverage. And this is corroborated in Prof. van der Neever's report through the International Labour Office, which states that there are very small gaps, if any, in our universal healthcare coverage. The quality of that healthcare, there we can have an argument on. We're of the opinion it's poor quality healthcare and we need to fix the quality. But how you do that is not this bill. We don't think this bill is going to address the quality necessarily. We don't even think that it's focusing on the right end. We think, and we've explicitly stated this, and we agree with Prof. van der Neever's findings in his report, we've got governance and management issues in the current healthcare sector. We can follow the Competition Commission's health market inquiries recommendations to significantly improve the quality of healthcare, which would facilitate eventually, if we want to get to a point where everyone will be able to get mandatory medical aid membership, but get more competitors in, because that actually drives price down. We have not seen in South Africa that a monopoly purchaser leads to efficiency. We can think of Eskom specifically. It does not necessarily lead to efficiency, and we're very scared to go down this route with something as critical as healthcare. Do we think that the minister having sole oversight or the sole right to compete, to appoint people for a fund of this magnitude is a massive worry? Given South Africa's history of corruption, given the fact that we've now had an SOE report that shows in the middle of a pandemic, we had officials plundering money meant for literally saving lives. Yes, we are extremely worried about having a fund of this magnitude under political oversight. We think what we should do is follow the example of the rest of the world, which is, whilst we can look at centralizing pooling, we should decentralize as much of medical healthcare planning as we can to reduce the risk of losing funds to corruption. And that is one of the findings that Prof. van der Neever also finds in his report, and explicitly states we should decentralize as much as possible and follow the examples internationally where we make sure that the piggy bank is not that big. It's a tragic state of affairs that we're here, but the harsh reality is we need to face that whenever a fund like this is, it's a massive problem that we will most likely have corruption issues. Do we think this bill will pass constitutional muster? No, our submission explicitly states we don't think it will. We don't think it will pass muster for rationality. We don't think it will pass muster for feasibility. And since a large part of the bill would be depriving the rights instead of just adding to rights, we think it will not pass that. I'm not a legal expert, so don't quote me on this, but from our consultations with advocates, of which we've had many, they're of the opinion that this will not pass that muster and they will eventually get to that point. Honorable, I think it's Havard, I don't know if I'm correct, pronouncing it correctly, who asks, what about the Constitution? We explicitly, we're not dismissing Section 27(2) of the Constitution. We're of the opinion that access to healthcare is something. It's not a right to healthcare, it's a right to access to healthcare, but we already have access to healthcare. We've got an extensive public healthcare sector that we spend billions of rands on every year. So it's not that there's nothing. There is an extensive public healthcare sector that is already well funded from tax money. We need to ensure to just fix that up. That means we don't need to rehaul the whole system We need to fix the system. We've got a system that is leaking, that is prone to corruption and mismanagement. And if we just fix that system, then we can give a realization to access to healthcare, because realistically, you do have that. It's just access to poor quality healthcare. This can be fixed. As it can be fixed quite easily if we just listen to the several reports that have been commissioned already and that have been stated. Yet we've chosen an alternative that is vastly unaffordable and that does not address the central problems that we've got. Honorable Ismail asked for alternatives. I think we've exhaustively stated what our alternative is. I think you can go and have a closer look at the health market inquiry from the Competition Commission in 2019 that stated what they think is necessary to address the problems. The issue is that this bill does not address those problems. So the reason we're not focusing on specific instances or sections of this bill is because we think the starting point, quite frankly, is wrong. Going to a single purchaser is not something that should be done, and that's why we're against the bill in its entirety. And we're of the opinion the bill should be retracted, redrafted into something that much closer follows the recommendations of the Ministerial Advisory Committee on Health, the NDOHs. This is from the early 2000s, as well as the most recent ones, the Health Market Inquiry of 2019, which have extensively done diagnostic exercises. Just see who I'm missing here. Then Honorable Jacobs stated, do we differ with the technical analysis on the health need share? If you're stating that it's basically along the lines of, do we want the inequity in healthcare to continue? I think our position is clear that we don't think the status quo is sustainable. We don't think the NHI is a solution, however, and we don't think the NHI is going to lead to more equitable access to quality healthcare. It might be more equitable access, but it's not going to be quality healthcare. And even on the equitable side, we're not convinced. Although there is a problem in the distribution of funds, in delivery, it's not necessarily a problem in distribution of funds. South Africa spends a lot, literally billions on healthcare for significantly worse health outcomes than comparable countries. This is facilitated in Prof. van der Neef's report as well, where he looks specifically at maternal mortality rates. South Africa has maternal mortality rate almost 3 times that of countries with comparable healthcare spend. Now, this would imply that the problem is not on the purchasing side, the problem is not on the financial side, which is what the NHI bill is trying to suggest. It's much more on a governance and a management side and on the service delivery side. And this is what we should be addressing, is why, when we spend so much money on healthcare, are we getting such dismal results? And this is where we think the focus should be, is let's look at the system we have and let's look at why it's not working, rather than dreaming of a system that we think we might have one day, and which is unaffordable and which we can't actually implement. The much more viable alternative is to just fix the current system, get clean audits in our systems, get rid of the crooks. That would work. Our interpretation is based on ideology, was stated by the Honorable Jacobs. That might be true. I would posit that the NHI bill is also based on the ideology of the ruling party who implemented it. From our perspective, what do we make of the majority of poor people? We obviously want everyone in South Africa to have access to quality healthcare. We think that's something that should happen. We don't think that this bill will facilitate it. In fact, we think this bill will achieve the opposite. It will reduce the access that people on private medical schemes have at the moment, whilst not necessarily enhancing the access of people who aren't on these medical schemes. And that means, from our perspective, this bill is not going to achieve what it sets out to do. In fact, it's a very high risk, complete reform of the system without doing proper risk analysis, without doing any of these things. It's almost reckless the way we've steamrolled ahead with a bill that has not been costed properly, that has done very little in the form of feasibility studies. And this you can read further. You can contact Prof. van der Neef if you want. We'll provide contact details. We provided resumes of the experts that we used in our written submission as well. And his report should be available where he more extensively deals with this. The ethics of healthcare, I'm curious about the question as to, do we not want people to have access to healthcare, which we unequivocally state, of course not. We want people to have access to healthcare. We've stated this repeatedly. We stated this in our presentation. We're not of the opinion that poor people should not have access to healthcare. We're not of the opinion that anyone should not have access to healthcare. We're just of the opinion that this bill will not actually succeed in extending that coverage. It will not succeed in anything other than destroying the private healthcare sector with negligible benefit otherwise, which means we're actually very concerned about access to healthcare for everyone. We don't think this bill is going to achieve it. We've stated our alternatives repeatedly. And then regarding a legal challenge, at the moment, we're still in consultation and we're part of legislative process. We think, and our findings and our submission, written submission that we submitted in 2019 explicitly states that we think this bill should be withdrawn. There should be a lot more work done on something that is proposes such radical reforms as what this one does. We don't think it's going to pass constitutionality, and we are ready to have the Constitutional Court hear that challenge. If necessary, we will take the legal route as well. I think that is everyone. I thank you for your time, honourable members, and hopefully we can get to a conclusion on this.
Thank you very much, Mr. Mulder, and to your team for coming to present. We, honourable members, we have come to the conclusion of our meeting for today. Mr. Mulder, I will give you an opportunity. Oh yes, I will come back to you, Honourable Van Staden. Mr. Mulder, I will give you an opportunity to give a closing remark, and then I will go back to Mr. Van Staden's point, which he raised earlier before we close this meeting.
Thank you, Chairperson. Our closing remark, Solidarity is of the opinion this bill is unaffordable, unnecessary, and unworkable. We need to ensure that when we extend the access to healthcare, we extend access to quality healthcare. Having access to nothing does not make us more equal.
Thank you very much. Honourable members, we are done with the presentations for today. I need to thank you for your indulgence for this week. Before we close, and before I'm going to make some closing remarks and give us an indication of the next date, I'm going to give Honourable Van Staden an opportunity to raise the point which he wanted to earlier this morning. Honourable Van Staden.
Thank you very much, Chairperson. Now, I wanted to ask a question Tuesday, but I completely forgot about it, and I think we just need to get clarity on the matter. And it's about the submissions which was made via email and delivered to Parliament and so forth on this NHI bill. I just want to know, and I think we must just get clarity for ourselves, due to the fire that happened in Parliament recently, did it have any effect on the submissions which was handed in via email or delivered to Parliament? Where are the submissions currently? And just to get us as members refreshed again, because I see there was messages sending now from people looking for documents. Can we just be refreshed again how the system is working to draw the necessary submissions which was made by stakeholders to us to get the document again, please? Thank you, Chair.
Thank you, Honourable Van Staden. It is noted what you are requesting. I'm certain it's also captured by our committee secretary. We will revert to the committee with the answers to your questions. Thank you very much. So, honourable members, we have come to the end of today. I wish you a wonderful weekend. We will resume with the NHI public hearings on the 8th of February, and this meeting is therefore adjourned.
Good day, everybody.
Bye. Recording stopped.